scanning EM, and there are some holes over there. And if the descemet membrane is attached over there and the air escapes from the holes, this will get into the anterior chamber, as we see when we do DALC often. And if the descemet membrane is attached there, this air will leak underneath the predescemet layer, through the predescemet layer, but anterior to the descemet membrane to give you this type 2 bubble. So with that kind of information, we thought in this animation, if you go and clamp those holes, then we should not get any escape of air and not get a type 2 bubble. So this is what we did. We invented this PDEC clamp, and this is an innovation keeping to the theme of this session, with a hole on the side for the right-handed here and for the left-handed on the other side. And the configuration of this is to meet or match with the configuration of the peripheral cornea. So there's a hole in action, and you can see you have to center it properly. That mark there tells you where the hole is. And once it's centered properly, there's a clamp, a screw clamp. You can tighten that to hold this, inject the air with a 30 gauge needle. Doesn't matter what depth. The bevel in this case is pointing up towards the endothelium. And what you'll notice is not a single bubble of air escapes anywhere. So you can inject at your leisure. All the air is building up in the tissue. The intra-tissue pressure builds up to the right level, and then the bubble starts to form. You can push your needle into the bubble and expand it further. Then you withdraw your needle, open your clamp, and you're ready to go ahead and dissect that tissue for your PDEC procedure. So I think it's the same video. Going to start here. So this is it. After, you can see the clamped area, there's no air. And this is the extent to which the bubble had gone, and then it deflates as you take your needle out. So in this clip, you will see in a patient, you do that, and you can cut that tissue out. It will scroll exactly like the DMEC tissue with the endothelium outside. You tap it into the nozzle. This is a very crude way of doing it. Nowadays, you have very fine cannula, etc. You pop it into the eye. You can open it, whichever strategy you want, put a bubble underneath and put it in place. So this PDEC operation has the advantage, as you see over here, it gives you the vision just like that of a DMEC, but you can use any age donor, because we've been able to get this PDEC tissue from donors age 1 to 2 to 4 to 9, etc. So the endothelial density will be high, but the disadvantage is that the size will never be more than 8 millimeters, because that's how far that bubble goes. So you usually get less than 8 by the time you've refined it. So I think that is more than made up by the endothelial cell count of younger donors. And if you believe in hemi-DMEC, then clearly you have more in PDEC than a hemi-DMEC. Now, this is another innovation. This is from Nicholas Pereira, and we've jointly written this paper. He's already presented it at the American Academy and the ASCRS meeting. So he said, this one avoids the type 2 bubble. So instead of putting a clamp, all you do is, where the red arrows, you go and score the descemet membrane, just like you would do for a DMEC, all the way at the periphery. Then when you inject air, that air at the periphery will not go anterior to the descemet, it will just escape out. It will not cause a type 2 bubble if you've already scored at the periphery. So without the clamp, you can get a consistent type 1 bubble, eliminate the possibility of a type 2 bubble, but the intra-tissue pressure control is lost because a lot of air keeps escaping and you don't know how much you need to inject, and you often have to change the syringe. And you push it in too much, it can burst the bubble. Now, moving on with the innovation, which is relatively new, is that to measure the elastin content of the predescemet layer and the descemet membrane, other parts of the cornea. So trabecular meshwork and predescemet layer have the highest elastin content. This is the predescemet layer, a lot of elastin. This is the PDEC tissue, and this is DMEC tissue. The elastin on the descemet membrane is concentrated in a band at the anterior surface, corresponding to more or less the bandage zone. So imagine the PDL, if you stretch a rubber band and you leave it, it'll come back. But if you stretch a rubber band and stick it on a piece of paper, which is like the descemet membrane, it will curl this way with the paper outside. So that is why the descemet membrane always scrolls with the endothelium outside. And this is a section of the human cornea, and you can see not just an isolated tissue of PDL and desmis, but in the intact cornea, you can see very clearly with this polyclonal antibody for elastin, you can see that the PDL is very clearly delineated. And this has also been shown by Keith Meek with the on-face scanning electron microscopy, that this layer has more elastin than anywhere else in the cornea. So there is this biochemical identification of the layer as well. And you can see over here, the DMEC tissue on the right column, how it scrolls compared to PDEC tissue and the PDL on its own. But the proof of the pudding is here. If you take some elastase enzyme and you put it on DMEC tissue, over time, it will spontaneously unscroll and become flat. And if you do a section of that, you can see there is degradation of the elastin as in the control where it's not. And it's been written in books and journals that it's the swollen endothelial cells that cause it to roll this way. But if you put this space and take away the endothelial cells, you will find it still scrolls exactly the same. So it's not the swollen endothelial cells, but the elastin that makes it do that. On the basis of this, we've also recently shown that, coming to corneal pathology, that just like you have the type 1, type 2 and mixed bubbles, you get type 1, type 2 and mixed desmis membrane detachment spontaneously. So here the PDL and the desmis membrane have detached. And these are examples of that. Even histologically, we can show that when you have a type 1 desmis membrane detachment, the PDL can be seen on histology, and it's usually a taut straight line on OCT, and similarly a taut straight line on the slit lamp. And here's another example on your right, where we've seen that if long-standing desmis membrane detachments get populated with keratocytes, and they can cause contracture, shrinkage, very difficult to put back. Here are mixed types. We can see that there are 2 lines over there, and then over here, it's a mixed type where the desmis membrane has ruptured, but that PDL is intact and this has curls. So these are some other examples of that. But what we've seen is even with Moran's ulcer now, there's a spontaneous type 1 detachment. And to cut a long story short, after 2 years later, they did a cataract operation with implant, leaving that desmis behind. And there must have been a slight puncture somewhere because there was endothelium growing on the posterior surface of the cornea. Then to finish off with this acute hydrops, we had said long back that acute hydrops is due to rupture of the predesmis layer and the desmis membrane. And that's what was later shown to be the case. So this is ectatic graft in a keratoconus eye, which developed acute hydrops, and you can see the type 1 detachment, and which had a rupture in the desmis membrane and PDL. And here's one example of that. So based on that, Professor Moran suggested that you could actually mark that area and approximate the torn edges of the predesmis layer, leaving the desmis torn and scrolled away, and you get a 40% reduction in edema within a day. So that's one, and he took that as evidence that the predesmis layer tear is contributing to acute hydrops. But this is a very interesting observation that came from Melis's group. They were doing Bowman's membrane transplant and dissecting thin corneas and thick keratoconus corneas. When there was desmis membrane detachment alone, there was no acute hydrops. But when they inadvertently penetrated right through the predesmis layer and desmis membrane, they got acute hydrops. And they questioned that are desmis membrane detachment the root cause of corneal hydrops, and concluded that they were not. So we responded to them saying, but we have tried this experiment in normal human corneas, and if you slip at the back and put it on an artificial chamber and raise the pressure to 60, you don't get acute hydrops. So the third key component is that you need not only tear in the predesmis layer, but also in the background of the abnormal collagen and glycosaminoglycan content of the keratoconic cornea. So they wrote back by saying they 100% agree, and that this is indeed what they think is the case. And that's where the story is at this point. So in summary, as we learn more about the predesmis layer, now the American Association of Ocular Oncologists and Pathologists have published it in Yanoff and Fine's book, calling it the Dua-Fine layer, but that's a different story. Its relevance to corneal surgery and pathology continues to emerge. And the next area we're working on is glaucoma and desmitoceles, where we think it will give us some answers in the very near future. Thank you.
Professor Dua, thank you so much for that amazing talk. There is a question regarding the preferred way of marking your PDEC graft for proper orientation.
So it's like DMEC. You can just go by the scroll or put an F or an S mark. So what we tend to do is like we do a trifold. So once you've cut the tissue, it's lying with the endothelial surface up. You can fold it so the endothelium is inside, and then put your F mark. And then when you pull it into the eye with the forceps, it goes in stroma up, and its natural tendency is then to scroll the other way so it opens. So that's what we do.
Yes, so Professor Dua, so you know, here in the US, we have a lot of pre-prepared tissue to make life easier for the surgeon. Is this PDEC clamp something you think that will be shared with eye banks? Is that going to vary from country to country? What are the plans for the PDEC clamp?
It is commercially available by Yanap, and I must say that I get no royalty from them for this, nor did I get any initial down payment or anything. It's just an idea they took and they developed and built. So having said that, many people, in fact, in Egypt, there are some people who've gone totally from DMEC to PDEC. They use the clamp. It's reusable. It's not disposable. But if you don't have the clamp, you can try that method which Dr. Pereira has just developed, just coring. And I think Frank Price's group has also published on the same method, which was originally Nicholas's idea, and scoring at the periphery. So that's an option. But SightLife, I think, was preparing, at least in the brochure, they say we will give you pre-prepared PDEC tissue, and of course, DMEC and DSEC and so forth.
For sure, Miracles in Sight Eye Bank in North Carolina is preparing PDEC tissue, as well as the Lions Eye Bank in Florida, I believe, and in Indiana as well. So they're all preparing it and delivering it to surgeons, not only in the United States, but globally as well.
Yes, yes. So I think the DMEC is still, I would say, the gold standard, because not many people have done PDEC in the same numbers. But if you have younger corneas, less than 50 years old, then, and somebody wants to use the tissue for endothelial keratoplasty, I think PDEC is the way to go. The risk of tear is much less.
There is a question. If the air injection is performed at the very periphery, the chance of obtaining a type 1 bubble should be much less. Is that true? That's the question.
There is one paper, the easier the access is to those fenestrations, the more likely you are to get a type 2 bubble. And those fenestrations are at the periphery. If you are central, and we know with DALK experience that if you are central and you are deep, then you don't get a type 2 bubble as often. Even otherwise, it's about 85% of the times you get a type 1 bubble, and 15% of the times you get a type 2 or a mix. So the chances are you will get a type 1 anyway, but if you are more central, then you are less likely to get a type 2.
So in that regard, Professor, do you find that there are any particular risk factors, any particular characteristics, either older, younger, any sort of characteristics that lead more to a successful type 1 bubble as compared to a type 2? Well,
in this context, you know, because here we have healthy corneas and healthy donor eyes, there isn't any. But if you are doing a DALK, and if you're doing a DALK for scarred corneas following infections or trauma, then you are more likely to get a type 2 bubble than if you're doing for keratoconus, which is the commonest reason we do it for. We've seen now, it's again, this is anecdotal, that the deeper the scar, the more likely you are to get a type 2 bubble. Because if the predismissed layer gets involved in the scar process, then it doesn't separate, and by the time you're pushing more air, it finds these fenestrations and goes in. And there's no way you can clamp in the dark.
I have one final question. You had mentioned glaucoma and desmetocele. As the theme is innovations, if you can clue us into what the future looks like in terms of glaucoma and desmoid.
Oh yeah, sure. So, well, desmetocele, you know, we've seen, and I think Sadir Hanush has seen, and Amar Agarwal has actually published 2 cases, and I've got a whole bunch of cases, more than a dozen, where you either have only the PDL or stroma and PDL to what we call a desmetocele. And you can see this by histology. In some cases, histology is not that often we get a chance, but by OCT you can see. So it's not pure desmetocele. And you know, in the textbooks, people have written all the time that desmids resist perforation. That's because the PDL is on it. If the PDL goes, then chance of desmids resisting is poor. But coming to glaucoma, it's already been shown, and there are 2 posters. One of them won the first prize by an author from India. This was at the ACSRS, that when they do deep sclerectomy, and if you remove the pre-desmids layer and leave only desmids behind, the outcome is much better. But if you leave the pre-desmids layer behind together with the DM, then the outcome is not so good. And they showed this by looking at successful and unsuccessful patients, or not so successful patients, and the block they had removed by EM to see if the pre-desmids layer was there or not. And intraoperatively, they were able to put the trypan blue dye and do the flow videography to show that the oozing of aqueous was much more quicker and more of it in eyes where the pre-desmids layer was removed than in eyes where it was not removed. So it might be a little extra step in the procedure that might be required if the evidence confirms what these doctors have shown. So what we have done is we performed deep sclerectomy in donor eyes. So we get not only the block, but also the base. So we get both components of that operation, and we're looking at that to see what is happening when somebody thinks they've done a neat deep sclerectomy. I'm not doing it. The glaucoma surgeons are more experienced in it, to see this, and we're doing the laboratory side of it to see what there is. But even in aqueous outflow, you know, because what we found, and this is a grant application which we asked to revise and sent back to the international, the Glaucoma Foundation in New York, that if the tensile strength of the pre-desmids layer is disrupted, as in full thickness grafts, then the incidence, we know when penetrating keratoplasty, the glaucoma incidence is much higher than can be accounted for the use of steroids alone. And in DALC, it is much less because this layer is left intact. So are we altering the posterior biomechanics in a way that's causing the trabecular meshwork to collapse? So because of alteration in biomechanics, is the gene expression changing, and is a consequence of that? So very, very early days, but these are the hypotheses that we're exploring.
Thank you so much, Professor.
Exciting work. Thanks for joining us today. We really appreciate it. We are going to move on to our next speaker. So I would like to introduce Dr. Noriko Koizumi, who is chair and professor of the Tissue Engineering Laboratory at the Department of Biomedical Engineering, Doshisha University in Kyoto, Japan. Dr. Koizumi is internationally known for her work in corneal epithelial and endothelial biology. And she's part of the team, along with Shigeru Kinoshita, that implemented the first in-human clinical trial of endothelial cell injection for corneal edema. So Dr. Koizumi is very dedicated to her work in advancing the science, and she's joining us from Japan, where it's about 25 minutes after midnight tonight. So Noriko, thanks for being with us, and I'll turn it over to you.
Thank you, Sanjay. So hello, everyone. Okay, my name is Noriko Koizumi. So first of all, thank you very much, Ashiyana and Sanjay, for inviting me to this exciting virtual meeting. So it's my great honor and pleasure to be here and grant support. Well, the goal of our research is to develop the novel and evolutionary treatments for corneal endothelial dysfunction. In 2003, we got started with research to develop cultivation protocol of human corneal endothelial cells and its application for cell-based therapy. And more recently, we are also working for pharmacological treatments for Fuchs endothelial corneal dystrophy. And in this presentation, I'll talk about recent studies developing cell injection therapy by using cultivated corneal endothelial cells in combination with Rho kinase inhibitor. We previously reported that the Rho kinase inhibitor Y27632 promoted cell adhesion of primate corneal endothelial cells in culture. This discovery led us into the concept of cell injection therapy. Let me introduce the surgical procedure. First, we gently scraped off the patient's corneal endothelial cells from the descemet membrane and inject the cultivated allogenic corneal endothelial cells into anterior chamber with media containing ROCK inhibitor. To increase the efficacy of the cell adhesion on descemet membrane, we keep patient's eye at face down position for 3 hours after injection. The molecular mechanism of ROCK inhibitor on corneal endothelial adhesion is shown in this slide. When we recover the cells from culture flask, raw ROCK and MLC signaling is activated in suspension cells, and the expression of focal adhesion complex is suppressed. But inhibition of raw ROCK signaling by Y27632, it downregulates the action construction and upregulate the expression of focal adhesion complex, and it promotes the cell adhesion to the substrate. And we performed animal studies using a monkey allogenic transplantation model and confirmed the recovery of corneal transparency. We obtained the proof of concept of carrier-free transplantation of cultivated corneal endothelial cells, and also efficacy and safety data from 1 year observation of monkey model. In terms of the cell production, there were several problems associated with human corneal endothelial cell culture, such as limited proliferation, fibroblastic transformation, and cell density decrease due to senescence. We developed several techniques to solve these problems, and now we can expand healthy polygonal cells with high endothelial cell density, more than 2,000 cells per square millimeter, up to passage 5 culture. And in theory, we'll be able to obtain enough cells for more than 200 cell injection surgeries from one donor corneal tissue. Then we conduct a preclinical study of cell injection therapy using cultivated human cells in a primate model. Endothelially denuded monkey eyes that underwent cultivated human corneal endothelial cell injection with ROCK inhibitor recovered corneal clarity. The cell density was more than 2,800 cells per square millimeter, and the corneal thickness was 538 micrometer. And there was no abnormal findings by gonioscopic examination, and the IOP elevation was not detected. Histological examination revealed the healthy polygonal monolayer expressing function-related proteins was reconstructed in those eyes. The histological examination of systemic organs and biodistribution test using PCR showed the systemic safety of cell injection therapy. Under the permission from the Japanese government, we started the first-in-man clinical study of cell injection therapy in December 2013 at Kyoto Prefecture University of Medicine. Let me share a short video of the surgery. We made 1.6 millimeter linval incision and gently scraped off host corneal endothelial cells from 8 millimeter diameter area of descemet membrane with silicone needle with irrigation. Then we transplant cultivated allogenic corneal endothelial cells by injection with media containing 100 micromole of ROCK inhibitor by 26 gauge needle. The surgical procedure is very simple and it takes 10 to 15 minutes. This is the first patient with bural keratopathy induced by argon laser iridotomy. Before treatment, she showed severe corneal edema with Descemet's fold. Her best corrected visual acuity with decimal fraction was 0.04, and her corneal clarity recovered in 4 weeks after cell injection therapy, and she obtained 1.2 vision. She keeps clear cornea and excellent vision for 5 years until now. This is a second case with Fuchs dystrophy. He also recovered clear cornea and good vision. And good vision and clear cornea had been well maintained for 5 years. This table shows the 2 years results of first-in-man clinical study, which involves 11 eyes with endothelial dysfunction. 7 eyes were Fuchs endothelial corneal dystrophy, 2 eyes were argon laser iridotomy-induced corneal edema, 1 eye with PEX-related corneal edema, and 1 eye with intraocular surgery-related edema with IOL suturing. All of these 11 eyes were pseudophakic. Here is a slit-lamp photograph of 11 patients before surgery. All of these eyes showed severe corneal edema, total corneal edema, and visual acuity was severely impaired. After surgery, recovery of corneal endothelial function with visual improvement was confirmed in all of 11 treated eyes. As you can see here, the clear cornea, the good vision were maintained for 2 years. Recently, our colleague Dr. Kosaku Numa in Kyoto Prefecture University of Medicine published 5-year follow-up data of the same patients in ophthalmology. We can see that 10 of 11 cases, except patient 4 who showed borderline corneal edema, have kept good visual acuity with normal corneal thickness and a reasonable ECD for 5 years. Central corneal thickness at 5 years postoperative was within the normal range in 10 of 11 eyes, and visual acuity improved in 10 of 11 eyes. And the logMAR visual acuity had improved from 0.876 to 0.046. Local or systemic adverse events such as immunological rejection, uveitis, or IOP elevation associated with cell injection procedure were not detected in all treated eyes during the 5-year follow-up period. 1 eye received trabeculotomy surgery for steroid-induced glaucoma. In terms of the corneal endothelium, polygonal monolayer of corneal endothelial cells was observed in 10 of the 11 eyes 5 years postoperatively by contact specular microscopy. You can see here some goutte in postoperative endothelium in patients with Fuchs dystrophy, because we did not peel off the patient's Descemet's membrane in our protocol. However, since it is widely recognized that the Descemet's membrane thickening with goutte causes visual impairment in Fuchs dystrophy patients, so we are currently encouraged to change the cell injection protocol with Descemet's membrane removal in future. This graph shows the postoperative change of endothelial cell density. The mean ECD at 5 years was 1,200 cells per square millimeter, ranged from 600 to 2,000. So compared with the previously published data regarding the surgical outcome of DSEC and DMEC, our findings show that cell injection therapy seems to be equivalent to the clinical outcome of endothelial transplantation. What's the merits of cell injection? This is a simple and less invasive surgery, and we expect patients obtain good visual recovery with less astigmatism, and it will be a solution to donor shortage in many countries. Currently in my laboratory at Doshisha University, we are working for developing quality standards of culture corneal endothelial cells compliant to FDA or Japanese FDA regulation. And also we are keen to develop the technology for preservation and transportation of cell product. This slide shows our concept of cell product in near future. We are planning to culture the GMP grade cells, incorporate CPC, and recover the cell from culture flask and put into vial containers as a form of cell suspension. If we can deliver these cells to hospitals, the ready-to-use vials to hospital, the surgeons just aspirate and mix these cells with ROCK inhibitor and inject them into anterior chamber of patients. The development of vial product is our dream because it's a critical step towards the universal application of cell injection therapy. This is a summary slide which shows our idea of future therapeutic modality for corneal endothelial dysfunction. Along with DSEC or DMEC, cell injection therapy might be an optional treatment for endothelial dysfunction because it's a less invasive surgery applicable for a wide range of corneal endothelial dysfunction. Currently, clinical trials of cell-based therapy using ROCK inhibitor or other technologies such as magnetic cell delivery are ongoing or going to start soon. For early-stage patients who still have some intact endothelial cells, drug therapies such as ROCK inhibitor with desmet stripping or other pharmacological agents preventing endothelial apoptosis might be developed for Fuchs dystrophy. Before I close, I'd like to acknowledge my colleagues and collaborators. Thank you very much for your kind attention.
Beautiful, beautiful. Thank you so much for that fantastic talk. Next up, we have Dr. Kathryn Colby. Dr. Colby has recently joined New York University as chairman of the Department of Ophthalmology after serving as chairman of my residency program, actually, University of Chicago. She is an internationally renowned academic corneal specialist with a long-standing interest in Fuchs dystrophy and an innovator of the Decimate stripping procedure for its treatment. Dr. Colby is the president of the Cornea Society, serves on numerous boards of directors, and is the U.S. chair for a multinational, multi-center study examining the role of Rho kinase inhibition in corneal endothelial rejuvenation. Thank you so much, Dr. Colby, for being with us. It is an honor. I hand it over to you for strip and Rho kinase inhibitors with Decimate stripping.
Thank you very much. It's a pleasure to participate in this innovative session with many friends and colleagues who are renowned cornea specialists throughout the world. I have no relevant financial disclosures. I will be discussing use of a non-FDA approved medicine, Reposidil, and as well as the use of Nitarsidil, which is approved in the US for glaucoma, but not for endothelial rejuvenation. So we've known for a number of years, it's actually about 8 years right now, that the endothelium in Fuchs dystrophy has the potential to rejuvenate and cause corneal clarity. And this came from a number of different observations, some of which are from Dr. Koizumi and Dr. Kinoshito, some from Dr. Mellis, and then isolated case reports of inadvertent descemetorrhexis. I began my investigation of Decimate stripping only in 2014. This is the first patient shown here. Now he is 6+ years after his Decimate stripping and retains 20/20 vision and is quite happy. And since our initial report in 2016 of our original series, multiple authors have presented increasingly more successful series. And these were done, our original cases were done without ROCK inhibition. So to ensure success with Decimate stripping, the first and most important thing is to pick the right patients. Patients do need to be symptomatic from Fuchs and have only central guttae of really no more than 5 millimeters in diameter with preserved peripheral endothelium. And you can evaluate the peripheral endothelium in several ways. If you have a confocal available, you can image the peripheral endothelium, but if not, you can actually look using specular reflection and a high-powered optic at the peripheral endothelium. But you really want to make sure that the guttae predominantly are confined to the central cornea. There is, as we know, corneal edema after removal of the Decimate membrane and endothelium. And so patients do need to be able to tolerate reduced vision which can last as much as 6 weeks after desmate stripping. And finally, they need to be able to and willing to have endothelial keratoplasty if the desmate stripping is not successful. I'd encourage you to avoid patients who are monocular, patients who have advanced Fuchs dystrophy with limbus to limbus guttae, patients who expect perfection, and patients without any symptoms. It's pretty common for me to see patients with early Fuchs dystrophy, and despite probing questioning, they have no symptoms. And those are not patients that you want to embark on a desmate stripping on, because if it doesn't work and they need an EK, you've taken an asymptomatic patient and given them a corneal transplant. Secondly, surgical technique really matters, and we've discovered this over the last 4 years or so. You want to remove as many of the confluent guttae as you can. It's fine to leave scattered areas of guttae, but if you're leaving a whole ring of confluent guttae, the peripheral endothelium will not be able to migrate into the central cornea. It's very important to be gentle with the cornea. We've seen published already case series where there's stromal scarring, and this results from digging into the stroma with either a reverse Sinskey hook or some other instrument. So very careful. It's really a stripping, not a scraping. You want to aim for a smoothed edge tear. In the series out of Mass Eye and Ear, they showed that when they went to a smooth edge tear, they had a 100% success rate, whereas before that it was hovering around 80 or 85%. And then finally, to ensure the best optical results, you want to try to center the des metatarsus on the visual axis. Here's an example of the surgical technique. This is in real time, and I show this in real time for people to be aware that it is really a very straightforward technique. So these are the Gorofoy forceps. I have no financial interest, but they are an excellent instrument created by Mark Gorofoy. And you can see the first, I'm going very gently. I'm not really digging into the stroma. And when I first try to go the first way, it doesn't quite work. And like with the capsulorhexis, sometimes you have to go the other way. And you can see here just re-grabbing. So this is basically the same maneuver as a capsulorhexis, only it's upside down on the dome of the cornea. And then with patients, and not an incredible amount of time, you're able to complete the des metatarsus. This is a 4 millimeter des metatarsus, and you can see the nice smooth edge. And the only place there's any irregularity is where you started the tear, which in this case is here. This patient recovered in 3 weeks and retains 20/20 vision. The final tip is using a ROCK inhibitor after surgery. As I mentioned in the introduction, there's several around the world approved for glaucoma. We know again from the work of Dr. Kinoshita and Dr. Koizumi that Rho inhibition promotes endothelial proliferation in vitro and corneal clearance in animal models. It was Greg Maloney from Australia who first showed that Reposidil could be used to rescue two slow to clear DSO patients. And this was published in 2017. More recently, Marion Maxey, a colleague from Chicago, did a small investigator-initiated trial showing that Reposidil increased cell count and decreased time to clearance in Fuchs patients. And then finally, there's been a case report, a single case report of the use of Nitarsidil in one case of desmate stripping. Here's one of my patients who had a 5 millimeter desmate strip with a phaco and used Reposidil, which she obtained online. It is not, again, FDA approved. Patients can obtain it online and we can observe them using it. And she cleared within 3 weeks and maintained excellent vision at her last follow-up and a cell count of about 1,300. And again, these are her own cells. So you can see here from this screen, I continually update this slide, that although we've discussed over 200 cases of DSO with Reposidil, vanishingly few have been published in the peer-reviewed literature to date. But you can see that there is an excellent success rate in recent series using Reposidil. And Mark Gorofoy, who has more than likely done the most of these in the world, at the NEOS meeting in June, shared that he had a over 92 success rate, and use of his Gorovoy forceps and the ROCK inhibitor really has enhanced the efficiency and speed to clearance of this process. And the photos are showing one of my patients with their edge of the Decimase stripping and the corresponding confocal. Now, of course, anecdotal and case series are very nice and give us something to go on, but the way to really prove that something works is through a randomized clinical trial. We are currently enrolling in a phase 2 multi-center, multinational trial of Reposidil after Decimase stripping, sponsored by the manufacturer of Reposidil, COA. Our recruitment has been slowed due to COVID worldwide, but we've currently randomized 3 patients. There's very strict inclusion criteria, and patients can only be randomized after the Decimase stripping meets certain pre-identified criteria. The primary endpoint in this study is endothelial cell count at 3 months. Of course, there are multiple exploratory endpoints, and a larger phase 3 trial will occur following the phase 2 trial, depending on the outcomes. So in conclusion, Decimase stripping has been shown to be successful in Fuchs dystrophy in up to 100% of patients with a clearance time of 2 to 6 weeks. It appears that Reposidil speeds up the process of clearing and turning non-responders into responders and increasing final cell count as well. There are remaining questions: the optimal patient population, the optimal size and shape, steroid effect, and what is the role of Notarsidil. We are ongoing with our randomized clinical trial and hope to complete enrollment by early 2021. Again, I would like to thank the organizers for the opportunity to participate, and please everyone stay safe.
Noriko, there's questions about antigenicity of the donor cells. Is there potential for less rejection? And along similar lines, when you did human to monkey xenografts, was there profound inflammation?
For the first question, that clinically we didn't, luckily we didn't observe any immunological rejection in our case series, in total 38 clinical study cases. But we are not sure what happened on the injected cells immunologically. And there is one paper published from Professor Kinoshita's department. Dr. Jun Yamada reported that immune tolerance induction after cell injection, cell transplantation in mouse model. But we don't know yet what happens in cell injection therapy in patients. And in our xenograft model, we gave the monkey the immunosuppressive therapy with tacrolimus. And also the picture was taken after 2.5 months. So after 3 months, the injected human cells will be rejected. So that is xenograft. So we use the immunosuppressive therapy.
That's great. Thank you, Noriko.
Thank you.
For Dr. Colby, several questions. If you can comment on if there's a minimum peripheral cell density that's required, also the dosing of ROCK inhibitor, and whether the femto laser is an option for dysmetorexis.
Okay, so no science on the minimum amount of peripheral endothelium. In one of Greg Maloney's paper, he mentioned 1,000. There's nothing magic about 1,000 versus 900, but you have to use your good judgment. If you look and the peripheral endothelium looks normal, and there's 900 cells, but there are no guttae and the cells look pretty good, you're probably okay. If I usually look superiorly, since I figure those are the most protected of the peripheral endothelium. If you do that same thing, and up top there's 500 cells, they're pleomorphic, there's guttae up there, probably that's not enough. But we have no evidence base to make a decision one way or the other. But clearly it makes common sense that more cells, healthy cells peripherally, are better. Regarding the dosing, again, no data, The clinical trial is looking at two different doses of the Repostol, the ROCK inhibitor that's being studied. So we should have some data about that. Greg originally used 6 times a day. I think a lot of us who are observing patients using this are using it 4 times a day, and that seems to work pretty well. I think if you know a little bit about the pharmacokinetics of the ROCK inhibitor, probably 4 times a day is adequate. And then finally, femto. There have been, I've at least reviewed some manuscripts looking at femto for making the desmetorexis. I tend to be a minimalist. The Gorovoy forceps are not inexpensive, and with that it's quick and straightforward to do them. I'm not sure that there's a big advantage with femto. Certainly it's more expensive, and there's a concern that you may create a bit of a ridge that will impede endothelial migration.
That's great.
Kathryn, do you not see at the edge of the bit you leave behind that the descemes membrane actually detaches and scrolls? Do you do OCT across the whole?
Yeah.
And because one would expect that to happen, because sometimes when you do that for a DMEC or DSEC, you see there are some little bits hanging rather than staying flat.
Yeah,
They're further out at the periphery.
That's a good point. I mean, I try not to go out to the periphery, and again, that smoothed edge tear seems to keep everything in place, based not only on clinical exam, but anterior segment OCT.
Kathy, clinically, when you're doing the procedure, preoperatively, before you dilate the patient, do you mark the central visual axis at the slit lamp? That's what I've been doing on my cases. It's much easier to strip when they're dilated. So I'll not dilate them, put an ink mark on the center of the visual axis according to the pupil, and then strip around that area. Have you been doing that as well?
Well, Mark, if I'm doing it with cataract surgery, I do dilate to do the cataract surgery. If I'm doing a phakic DSO or a pseudophakic DSO, I generally don't dilate them. And I find that, marking certainly will help preoperatively. I find that if you go to kind of high mag on your operating microscope, that you can see the edges of the guttae, and you've measured in the office, so you know kind of what you're looking at, but it's pretty straightforward at high mag to find the edge. And then I mark around the mark the central visual axis, and then I measure to make sure I'm within what I want to be.
You always stay within 5 millimeters?
Well, I don't want to say always. I have done some cases up to 6.5 in the largest diameter, and they've cleared. But I think if you want to have the best success, staying under 5 is probably going to give you your best chance.
Can I ask Dr. Koizumi one question? Is that when this comes online, ready for use clinically widespread, will it be one company that will be providing it, or will it be that the special medium will be provided to eye banks to make their own? Is there any thoughts on this? How will it come to general use?
I think practically it is very difficult to culture the cell in an individual university hospital or any place. So to keep the quality control, it must be much easier for the company prepare the cells and deliver to clinics and hospitals. So because even if we establish the cell culture protocol, it is a little bit difficult to make the same quality of cells from different donors. In reality, my company should work for that.
I want to thank, first of all, our esteemed faculty. I mean, it's just a wonderful thing to have all of the noteworthy founders of so many corneal transplant procedures all in one Zoom. It's fantastic, and we're grateful. And also, just to allude, for next month's course, the highlight is Dry Eye Desert, taking place on Sunday, October 18th. And we'll post that link coming up shortly on the chat box. So I want to take us into 2019 to 2020 corneal transplant publications, hot off the press. I have no relevant financial disclosures. So in PubMed, when we use the key terms cornea, transplant, and innovations, we receive 51 scientific publications, the main highlights of which are engineering of human corneal endothelial cells, corneal active storage machine, collagen-based corneal grafts, annual versus femtosecond bulk, Bowman layer transplantation inlays and onlays, ocular adhesives, ND-YAG laser desmetorexis, and biocompatible carriers, which will go through the highlights. Now with update on Bowman layer transplantation, the earliest and the most specific indicator of keratoconus arguably is the fragmentation of Bowman's layer. And so several years ago, Garrett Mells innovated the Bowman layer transplantation to help stabilize these eyes with advanced progressive keratoconus for both improving visual acuity as well as to stop disease progression. So this paper highlights a 5-year success rate of 84%. So how is it done? Starting with the Bowman layer graft preparation, a corneoscleral button is mounted onto an artificial chamber. The epithelium is then debrided with a wet cell sponge, and air is then injected into the stroma. Then trypan blue is then dripped over the corneal surface, and just inside the limbus is a 360-degree score using a 30-gauge needle, after which the Bowman's layer is delicately removed from the underlying stroma. And here we can see on the photograph on the right, the left scroll represents Bowman's layer versus your decimase and your endothelium. Your DMEC graft is on the right, taken from the same donor cornea. And so surgically for our host bed, what is then done? This is from Garrett Mells' group. A corneoscleral wound is then put and air is injected through the paracentesis. A 360-degree dissection is done through the midstroma using your manual blunt dull dissector spatulas. And then using a Bistec glide, the Bowman transplant is then placed into the anterior chamber and then unfolded. Now, in order to ease this process, intraoperative ASOCT has been shown in the most recent 2 years in publication for this technique, as has femtosecond laser. But studies have shown that with femtosecond, the grafts are thicker on the order of, say, 37 microns as compared to manual, which is about 11. We also have studies out there for inlays and onlays. Ocular adhesives are taking a wave as far as drug delivery, as well as ocular scaffold holding the cells that can undergo differentiation and proliferation. They're also being used for wound healing in cases of significant stromal loss. Smart contact lenses are being trialed to monitor and speed up the wound healing process through online sensing and on-demand drug delivery. Now, Dr. Koizumi and Dr. Colby gave wonderful talks. I just want to highlight a few papers that came up just to emphasize the fact that human corneal endothelial cells is really becoming sort of a hot topic in the last 2 years. And this paper on in vitro evaluation of the feasibility of slit lamp ND-YAG laser for the desmetorexis. So in this paper, 12 eyes that were not suitable for transplantation were trialed, 2 to estimate the laser parameters, and the following 10 that had Goutte to create a central 4mm central desmetorexis. And I would be curious after this to find out Dr. Colby's view on the use of ND-YAG laser for the desmetorexis. And what about the eye banking world? Well, we have a paper that was published that showed the use of a corneal active storage machine. Basically, what you can see here on the right in number one, that's the heart of the corneal bioreactor. And that's where the corneal tissue is placed. That chamber, it's divided into two, an epithelial chamber and an endothelial chamber. The endothelial chamber is maintained at 21.5 millimeters of mercury, and the waste of old medium is then removed into a separate chamber altogether. And what was shown was that there was a 23% improvement in terms of the corneal tissue as compared to organ culture after 4 weeks. So more to come on this, especially in the midst of COVID times, okay? So I am going to introduce the next feature of the course as we started up in April is the meditation. And especially in times like this, you know, we talk about innovation, we talk about building up, but the question is really, are we building upon ourselves? And there's a whole world of discovery within our own being. And so these next 10 minutes are a time for us to really go within ourselves, close our eyes, relax, and spend a few minutes of it, if you will, just sending your loving vibrations to all those that are really suffering in times of COVID. So without further ado, I will hand it over to Olubanke to put on the meditation by Dada J.P. Vaswani, my role model and saint of the century, to give us the guided meditation.
Meditation is the key to living a more rewarding, fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight as far as possible. Let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself and the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at his lotus feet, your arms around his ankles, your head resting on his feet. Say to yourself, here is true rest. Here is true relaxation. Now, relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember that all the while you are in the loving, immediate, personal presence of God. We will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest. Expand and relax. Shoulders. Lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. Relax, relax, relax. Let go, let go, and let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for this beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti, Shanti, Shanti.
Oh, well, thank you so much, everyone. I think I'm sure everybody is on an academic high, right? With all of the exhilarating talks and all of the exhilarating points. But if we can, in the midst of that, go within ourselves, that is, I would say, the epitome of it. And so I encourage all of us to take 10 minutes wherever we are in our day and sort of just get to know yourself. And that building block of 10 minutes a day is difficult in the beginning, but through time and through practice, just like anything, it gets better and better. And that innovation, that discovery gets far more exciting, where everything else has a new meaning. So thank you very much, everyone, for joining with me with that. I would like to introduce our next speaker. Now, the next speaker, Dr. Sanjay Patel, is a very good friend of mine, near and dear. He is a professor and emeritus chair of ophthalmology at Mayo Clinic in Rochester, Minnesota. He served as department research director from 2009 to 2012 before being appointed as department chair in 2012. And recently he completed his 8-year term in that role. With expertise in corneal transplantation, imaging, and clinical trials, he is a member of the Fuchs Dystrophy Clinical and Translation Research Program at Mayo Clinic. He is the author of more than 130 peer-reviewed publications and has served on the editorial board of ophthalmology since 2013. Moreover than all the accolades, he is a wonderful human being, and I have learned a lot from him through and through. So without further ado, I hand it over to Dr. Patel for Through Thick and Thin, a trusted companion in DSEC. Dr. Patel, over to you.
Thanks, Ashiyana. And again, good morning, afternoon, and evening to all of the participants. So I'm going to talk about DSEC and why it's a trusted companion. There's probably not so much innovation in this talk as there has been in some of the previous ones, but I think that it's important that as we innovate, we also test what we've innovated and measure our outcomes, and then kind of critically look at the science, the evidence to support whether this is something that we should continue doing. So these are my disclosures, none of which are relevant to this presentation. And I want to discuss a blast from the past, and then talk about what is thick and thin, and then whether graft thickness actually matters, and then talk about DSEC as a trusted companion. So the blast from the past starts with this case, which is a 63-year-old female that had Fuchs dystrophy. And I saw the patient in 2008 and did a DSEC with cataract surgery. Preoperative visual acuity was 20/40. And 16 months later, the visual acuity is barely improved to 20/30, but the patient's happy. And we saw this a lot with DSEC patients. Their overall quality of vision improved. And remained happy with improving vision through 7 years. Now the other eye started the same way 5 years later, but ended at 20/50, and the patient was unhappy. And when you look at the graft and central thickness, it's not what you would expect. The eye with the thicker cornea and the thicker graft was doing better. So this was actually a case that I presented 5 years ago at the World Cornea Congress back in San Diego, when we could have real meetings. And at that time, I actually presented a meta-analysis, which has now been published. And what we found was that there were 23 studies looking at this relationship between vision and graft thickness. Most of them were small and heterogeneous. Most of the studies did not measure best corrected visual acuity in a standardized manner. And ultimately, the pooled correlation coefficient was 0.2, which means the predictive value is about 4% that graft thickness actually influenced visual acuity. And so at that time, we concluded that there was insufficient evidence to link graft thickness to visual acuity after DSEC. Since that time, I'm happy to say that we have a little bit more evidence, but it's still only a little bit, and we'll talk about that in a moment here. So I had to ask myself the question, what is thick or thin? And the reason I had to ask that question is I don't actually tell my eye bank how thick to make my tissue, as I haven't really found a big or a significant difference in visual outcomes. But here's something that I found in the recent literature, that conventional DSEC is a graft greater than 150. 100 to 149 is considered thin, and that's probably where most of my grafts are. Ultra thin is 50 to 99, and now there's nano thin, 15 to 49. And there's clearly innovative ways to make the grafts thinner and thinner. But as I said earlier, we need to study the outcomes and what is the evidence for going thinner and thinner. So does graft thickness really matter? What's the evidence? Well, we do, since we published that meta-analysis, we do now have a randomized controlled trial comparing two different groups of graft thickness. This came out of the Netherlands from Moore Dickman, and they found a significant difference between DSEC and ultra-thin DSEC. So vision was better in the thinner group at 12 months. Now, the important thing to understand here is the ultra-thin DSEC group had an average graft thickness of 100 microns, whereas the DSEC group had an average thickness of 200 microns. And I'm not really aware of anyone who's typically transplanting a graft that's 200 microns thick. So this is actually the only randomized trial that I'm aware of that compares graft thickness. Just put that in context of what actually happens to vision after DSEC over the longer period. This is our own study. It's a 5-year prospective study with standardized vision measurements. And at 5 years, these patients end up with better than 20/25 visual acuity, and more than half of them reach that level. In this study, the average graft thickness was 155 microns. And I just want to point out what they were at 1 year. They were 0.18 logmar. And hold that thought as we look at some of the next slides here. The point here is these patients continue to get better. And so is a 12-month outcome actually appropriate to measure? So my next question is, can you compare DSEC to DMEC? And the answer is, well, of course you can compare it. And it's been done, as I'll show you. In my mind, I see these as two different procedures and therefore not necessarily directly comparable. But let's look at what's been found. This is the DETECT study, which was recently published, and they found better vision through 12 months with DMEC compared to ultra-thin DSEC. And a study, again, out of the Netherlands, asking the same question. They did not find a significant difference, though they may have been slightly underpowered at 12 months to show a difference. But leave aside the DMEC data and let's just look at the ultra-thin DSEC data here. The graph thickness for each of these studies is shown, 73 microns for the DETECT trial and 101 microns for the trial out of the Netherlands. And at 12 months, these are the visual acuities. They're very similar. And put that in the context of what I just showed you from our own study, which was not randomized, but was prospective and standardized. We're talking about a 1.5 letter difference over quite a wide range of graft thickness. Granted, this is through 12 months, and this may change, or it's possible all of these eyes continue to improve beyond 12 months. But the overall difference here is very small. So if it's not simply about graft thickness, what else is it? And just to simply show this, I mean, ideally we want to have a graft, a DSEC graft that's of regular thickness, not just in one meridian as shown here, but 360 degrees. But sometimes when they're cut unevenly. And then sometimes the donor cornea has a different curvature to the host and they don't fit well. And this can sometimes lead to trouble. So here's a patient who's 59 with Fuchs dystrophy, 20/60 in both eyes, underwent DSEC with cataract surgery. One eye ends up very happy and the other one not. And this time the graft thickness is not too different between eyes. So what happened to this patient? Well, here's a photograph, and this may not look like much, but this tiny fold in the graft here, which you can see against the red reflex, was an area where the graft never attached early on and took several months to close. And sometimes this will leave a macro fold, as shown here. You can see the patients had a YAG capsulotomy to do everything to get their vision better. But when you look at their actual vision quality, it's the posterior surface of that right eye. It's the aberrations from that surface that are upsetting the patient's vision. And when you replace that graft with a DMEC, the aberrations improve, the vision improves, and the patient's happy. So it's not simply about thickness. There's other components to patient's quality of vision after DSEC. So in this patient, it was a macro fold. And these are known to exist. Here's a patient with DLEC who had a pretty significant macro fold through the visual axis. And here's what I was referring to with DSEC is sometimes you'll get a wedge of the graft that doesn't attach early on and it slowly closes but may leave a fold that affects vision. And the macro folds are ones that we can see at the slit lamp. But if you look with confocal microscopy, many of these transplants have microfolds, and these lead to undulations in that posterior surface and therefore aberrations of that posterior surface. So I personally don't think it's all about graft thickness, but let's talk about DSEC as a trusted companion. We all know about the evolution of keratoplasty, and in my mind currently, the lower two panels are really where we're at for endothelial keratoplasty. And I'll show you how I use both of these procedures. For DSEC, we have pre-cut tissue, which we tree-fine in the operating room. And here we strip Decimate membrane as you normally would. This patient had the cataract removed at the same time. And then I usually peel the graft onto a bed of Healon over a lens glide for insertion, and then use air and close the wound, which is actually 5 to 6 millimeters in my hands, just to reduce compression of the tissue during insertion. There's many techniques, as we all know, to do this, and my advice would be to the starting surgeons is get used to one technique and do it well before you start, trying different variations. So in my practice, ideal eyes get a DMEC because it has similar graft survival to DSEC and similar, which is similar or better than PK. The vision may be slightly better with DMEC, and they actually have a lower rejection risk and therefore steroid use. Complex eyes get a DSEC. We really don't know what the graft survival outcomes are in these complex eyes. It's probably worse for DMEC because of additional tissue manipulation. And remember, these eyes have had other things done to them that their best vision potentials often decrease. So is that tiny gain in vision going to be important or not? And we really don't know if the rejection risk is higher in these complex eyes either. And then remember to consider non-ocular patient factors. So again, for starting surgeons, these are my recommendations, and this is still largely what I do. When I'm faced with a complex eye that's had a tube or a trab, post-vitrectomy, a phakic, AC lenses, I actually prefer to change them to PC lenses. These eyes, I do DSEC. But there's patients who can't lie flat for a significant period of time, or they're a thromboembolism risk. Sometimes it's patient preference based on post-op recovery. In my practice, where a lot of patients fly, they want to be able to fly back. And for monocular patients, I've had a couple of older monocular patients that had a DMEC bubble and went into delirium for a few days until they could see again. So, consider them for DSEC. And for DMEC, it's ideal eye that's really not had much done to it and no complications. Patients that have a failed PK, my go-to right now is DMEC, unless they have significant astigmatism that we would rather do a PK again. And the same for failed DSEC, where the eye is otherwise ideal. I replace that with a DMEC graft. So the bottom line is, I think both of these procedures have a role. And again, I would just advise surgeons that as transplant surgeons, we want to maximize the survival of our grafts, but also maximize the value to the patients with good visual acuity, good patient-reported outcomes. We have to remember our overall cost of care as well. So optimize your techniques, get good at a technique, make it good in your hands, individualize that care based on the patient, and then measure your outcomes to know that you're actually achieving what you want to achieve. So just to summarize this, the only evidence we have right now is that 100 micron DSEC grafts are better than 200 micron grafts. There's no trials that compare nano-thin to other thickness grafts. Vision can be affected by other factors and not simply central thickness. DMEC and whatever type of DSEC you may choose to do have roles in management, and then individualize that to the patient and think about your long-term value and outcomes. Thank you for listening. Okay, so we will move on, and our next speaker really needs little introduction, as he's well known all around the world, but it's still my honor to introduce Mark Terry, who's Director of Corneal Services at Devers Eye Institute in Portland, Oregon, and Clinical Professor of Ophthalmology. Mark has way too many accolades to list, clinical and scientific, but I just want to say I think we're all indebted to him for promoting endothelial keratoplasty in the United States in the late 1990s. and then more so just for his open willingness to teach us all, educate us all how to become better surgeons. So along those lines, Mark's going to talk to us about tips and tricks for troubleshooting DMEC. Thank you, Mark.
All right. Well, Sanjay, thank you for the introduction. Can you see my screen right now? Okay. First of all, I'd like to say that it is just so nice to see your faces. I have missed you guys in real life, and to be able to see people that I really cherish is a delight. It's virtual. It's not nearly as good as giving you a hug, but it's nice. And Ashiyana, thank you for putting this on. And thank you for the 10 minutes of meditation. We need to do that more often. I really appreciate that. Well, it's my task to talk to you about tips and tricks for DMEC. And I have no financial interest in what I'm going to talk about, although I do get unrestricted grants from Bausch & Lomb and Moria for the EKG breakfast that I hold each year. I think to start off, and this is going to be a combination of for younger surgeons and older surgeons, but we start off with just knowing the geography of DMEC. In our technique, we utilize a 3 millimeter or smaller main incision and 2 paracentesis sites. That orange circle that you see is the area that we strip, and then the blue represents the graft we place in there. I think it's important to be overstripping and having a little gutter, but not too big of a gutter between the graft and the recipient area. Most importantly, the graft should not overlap, and this is a tip for you. I don't believe the graft should overlap any of the incisions you make, the paracentesis sites or the main incision, on their posterior opening to the anterior chamber. If you have a graft that is going to overlap because it was missized or whatever, then it's better to leave the inferior paracentesis site uncovered and cover the superior paracentesis site. And we'll go into that later. It's important for rebubbling. Perhaps the best tip I can give you is to get on the website that Peter Veldman has thoroughly developed. The website is patientready.org. It's free, of course, and it has tremendous teaching tips on knowing the common conformations of the DMEC tissue. And if you go to this site, Peter will go through step by step on how to recognize and then open each of these configurations. And it presents you a very standardized approach of doing this DMEC surgery. So if you're starting DMEC surgery, or even if you're an accomplished DMEC surgeon, I recommend you look over this, this website. Now I'm going to go through some surgical tips rather quickly. We're going to look at tight scrolls and tapping maneuvers, tight scrolls and using an opening cannula, dealing with upside down tissue, recentering once the tissue is up in place, and that's one that I want to spend time on, getting rid of small peripheral air bubbles for fun, and then rebubbling at the slit lamp. So we have a 28-year-old donor, and it's all about chamber depth. It doesn't really matter how tightly scrolled the tissue is. If you can control the anterior chamber depth, you can open up even 28-year-old donors. Now we're fortunate this donor is already in a double scrolled fashion, and when you inject the tissue, you want to make sure that you can keep it in that double scrolled fashion. So keeping the chamber shallow when you remove the injector, and then you can start tapping if it's double scrolled already. But notice the chamber is almost flat, and that's the key. If the chamber cannot be shallowed or flat, then you won't be able to open up this scroll. And even when the scroll is, as you can see, trying to re-scroll, if you have flatness in the chamber, not completely flat, but nearly flat, you can open up any tissue. Now this is the Fogla cannula for a tight scroll. Sometimes you'll inject the tissue and it's still in a scroll and it's not in a double scroll formation. Well, you need to line it up with your previous paracentesis site. And then with this special Fogla cannula that injects from the sides, you get inside the tissue and give a quick little burst. Now the tip on this is just a quick little 1 or 2 bursts. And then you need to remove fluid from the anterior chamber, because if you allow that chamber to deepen with your fluid injections from the Fogla cannula, you're going to end up having it re-scroll up again after you work so hard to get it unscrolled. So a few injections into the depth of the scroll will allow you to get at least 1 edge open, sometimes 2, and then you can continue to unscroll it in the usual fashion. So getting the very tight scroll requires 1 or 2 sharp little bursts of fluid from a Fogla cannula or a Sarnicola cannula. There's other cannulas involved as well. And that will give you the start of an edge. Now, what about an upside down graft? The first thing is to recognize you have an upside down graft. This is a beautiful video from Paul Phillips, one of my former fellows now in Pittsburgh. And he's now put the tissue inside the eye. It has an S stamp on it. And look at how beautifully and easy it is to open this tissue. It's just, he feels that it's so easy that he's just going right ahead and opening up the tissue. And all is going well. And he's very happy about it. He's really pleased the fact that it opened so easily. But wait a moment, he's going to notice that it's upside down by looking at the S mark. Watch this. Uh-oh. He goes, oh my gosh, it's upside down. And he even points to where the S is, showing that the S is right there and it's backwards. So in order to flip this over, you need to inject along the iris surface with short little bursts, and that will flip your tissue over and keep it also unscrolled or relatively unscrolled. And so by doing that, you can then go on and finish it. And the S stamp was incredibly important to allow this to unscroll and to recognize that it was unscrolled upside down. Now this is the centering of the graft. Now I'm going to go through this. I want to first show you that I'm making a mistake right here in that I'm ready to put my air bubble inside the eye to unscroll, to lift the tissue up in place, but I've allowed the tissue to move out of the primary gaze, and by putting my cannula in that paracentesis, I've actually rotated the cornea, the patient's eye, downward, and when that small air bubble is injected, it's going to lift the tissue up and push the tissue over to the inferior area. So this is the wrong thing to do, a little air bubble. And right there, you can see it move the tissue this way. Sometimes it can move it dramatically in that area. So you want to keep your eye in primary gaze and keep it there and inject the air bubble, and that will lift the tissue straight up and prevent this decentration of the tissue. Okay, now, how do you fix this? Well, I've recognized that it's decentered, and I'm just trying to do a de sacrum maneuver. First of all, I'll deepen the chamber, get a smaller air bubble. Now I'm going to sweep, but the sweeping does nothing. And why does the sweeping do nothing? It doesn't move my tissue the way I want it. The reason is the air bubble here is pinning my tissue down. It's preventing this tissue from moving over. It's causing the tissue to stay right there, and it's blocking the tissue movement. So what we need to do is have the air bubble help us move the tissue. So we need to get this air bubble from here over to here. So instead of preventing the tissue from moving, it can push the tissue that way. And we want to have the tissue going downhill, not uphill. And so what we're going to do is we're going to rotate the eye in the direction we want the tissue to move. Rotate the eye in the direction we want the tissue to move. That will move my air bubble to the proximal end and also move so the tissue is going downhill. And now the air bubble can help push the tissue downhill with just a few sweeps. So it's the same sweeping maneuver, but we're not having our air bubble in the wrong position. So that doesn't work like that. Now we're going to simply grasp the eye, or you could have the patient look down if it's under local. Rotate the eye in the direction we want the tissue to move. And with just a few sweeps, now the tissue is in good position. And now we can complete the air bubble. So the point of the matter is that you want to have the air bubble help you, not have the air bubble hurt you. Now this is just something we do because I don't like to leave an air bubble inside the eye or a gas bubble inside the eye that has multiple bubbles. Because if I do that, I don't really know what the true size of this gas bubble is at the end. So here's a little maneuver you can do to get rid of and coalesce these peripheral gas bubbles. So look at these bubbles right here. And it's a very quick video. You flick two cannulas. So I'm just taking one cannula and using that as a base. And on the other cannula, I'm just sweeping down quickly. You can't really tap these open. You can't just use one cannula and tap the coalescence. You need to actually have a flick. Now, only do this, and this is a caveat, only do this when the air bubbles are peripheral. Do not try and coalesce two air bubbles that are in the central area, because if you flick this, you're going to damage endothelial cells. But if you do this outside of the area of the graft, you won't damage the endothelial cells. Here, watch this bubble right here. It's a very quick, and you'll see that this flicks off and will coalesce that bubble. And it's as simple as that. The reason I do this is so I can, at the end, know exactly what the size of my air bubble is and know whether or not it's going to be covering my inferior paracentesis or not. So how do we rebubble? This is a video. It has some sound, I believe. I hope we can play this. At the slit lamp. And when we're rebubbling, what we want to do is we want to use a IV extension tubing, because the idea behind rebubbling is that you do not want to have your syringe attached directly to your cannula, because at the slit lamp, you have to push the syringe down with one hand and keep this steady inside the eye. And doing that all at once is difficult and dangerous. And so what we do is we separate the movement of the syringe by the IV extension tubing, separate that movement from the stability of our cannula. We use a 27 gauge cannula and a 5 cc syringe, and this cannula will go through the previous inferior paracentesis. So we don't use any needles to cut through the cornea to place a rebubble. We go through our previous paracentesis, and I'll show you how we do this. And I have an audio on this. I hope it comes through. So basically, we're going to connect the cannula to the IV extension tubing, and at the other end have the syringe. And I can hold the syringe and the joystick of my slit lamp at the same time, and that gives me complete control of my focus. So here you see that's there. And I always give a 1, 2, 3 to the patient before I inject. And notice how steady my hand is with my cannula going through, and you want to release some fluid from the eye through the paracentesis.
Okay, so how was that having the eye rebubbled?
Unbelievably easy, no pain, and it was very quick.
Great.
So the point of this is that you want to have a rebubble not interfere with your clinic, and you want it to be safe and easy for the patient. And you want to have a complete view. With a slit lamp, you can tell the depth of your cannula. When you have the patient lying down, there's a risk of injecting into the interface, because when they're lying down, any edge that is now separated can also get in the way of your cannula. When they're sitting up, you can see with the depth perception of the slit lamp exactly what's going on. So in summary then, recognizing your various scroll conformations allows a standardized approach for DMEC that is totally reliable and will shorten your learning curve. So I recommend that you go to patientready.com. Unscrolling tissue is about chamber depth and understand the fluid wave movements. Even tight scrolls can be managed. So we use tissue that's 40 years old and older, but we sometimes get tissue that's 28 or 32 years old, because that's all that our eye bank has to offer. And we'll take that tissue because we can have proper control of the anterior chamber depth. And then resetting the graft requires a small bubble that is proximal and rotation of the globe in the direction you want the tissue to move. And that will allow you then to move your tissue from into centration. And rebubbles of the slit lamp with extension tubing is ergonomic, safe, and faster, and does not interfere with your clinic flow. Well, as always, I'd like to thank Charlie and my son Nicholas and Cindy for allowing me to give up my Sunday morning with you. And thanks very much for your attention.
As usual, fantastic talk there.
Super fantastic. And I just want to say, Dr. Terry, I'm looking forward to that hug post-COVID.
We're going to move on. Rajesh Fogla is no stranger to most of us, and he's the director of the Cornea Clinic and senior consultant at the eye department, Apollo Hospitals in Hyderabad. So Rajesh, as we all know, is a very busy surgeon, but also active academically with service to many journals and societies. He was the founding member and past president of the Cornea Society of India. And he's here with us today because he has a passion to teach at all levels. So who better to learn about DALK from? So Rajesh, over to you.
Thank you, Sanjay. Hello, everyone. I will be covering the topic on updates in deep anterior lamellar keratoplasty. I have no financial interest to disclose. We know that deep anterior lamellar keratoplasty, you remove 90% of the corneal stroma, leaving behind the host Descemet's membrane and the healthy endothelium. And that's the biggest advantage, that there is no risk of endothelial rejection. The indications are basically, we use it for ectatic disorders, corneal scars, dystrophies, degenerations, also in surface reconstruction, and sometimes in the management of infections. In the surgical technique, you basically have two surgical techniques. Either you do a layer by layer near Descemet's dissection that can, you can do it either manually or guided by the intraoperative OCT, or you can take the help of stromal injection of air, viscoelastic or fluid, and try and expose the plane of the pre-Descemet's layer. Recently, Dr. Sarnikola has tried to give a new nomenclature to deep anterior lamellar keratoplasty, including terms like subtotal anterior lamellar keratoplasty and total anterior lamellar keratoplasty, based on the findings of Professor Dua. But I think it's a little bit cumbersome. So for most practical purposes, we stick to descemetic DALK and pre-descemetic DALK for the current practice. In the pre-op evaluation, on slit lamp, you try and assess the extent of pathology, look at the corneal thickness. It's important to look at the scar, whether it's involving the Descemet's membrane or not. Any evidence of limbal stem cell deficiency, corneal vascularization, any lid margin pathology. In terms of diagnostic tests, regional pachymetry is essential. I try to use the anterior segment OCT for that, but you can also use the tomography to look at the regional pachymetry. And on the corneal ASOCT, on the corneal cross-section, you try to assess if the scar is involving the Descemet's. If it is involving the Descemet's, then you try injecting intrastromal air, because that's likely to have adverse outcome. The big bubble DALK described by Anwar and Teachman is the most popular technique of deep anterior lamellar keratoplasty, wherein using a 27 gauge needle, you inject air at 90% depth, and you create a surgical plane of separation. Now, Professor Dua has already explained about the pre-Descemet's layer or the Dua's layer and how it defines the type 1, the type 2, and the type 3 bubble, which is basically a mix of type 1 and type 2. Now, indications for big bubble DALK, you should avoid it in macular dystrophy, in eyes with very advanced keratoconus, where the central thickness is less than 220 microns, and if there are any scars involving the Descemet's. Because in these situations, the chances of getting a type 2 or a type 3 bubble is much more, and you can even have a spontaneous rupture of the type 1 or type 2 bubble as you're injecting the air. For trephination, plant depth trephination, commonly we use the Hesburgh-Barron trefine, which cuts down to a depth of 60 microns per quarter turn, or you can use guarded depth trefine, which have fixed depth blades. So you can cut 350, 300 or 400 microns. You can use the femtosecond laser to make shaped incision, like using the mushroom shape. And in certain cases, you can even use a diamond knife. If you're using a very large graft, then you can use a diamond knife to make the desired groove. I like to do an anterior lamellar keratoplasty to debulk, because it allows a deeper placement of the cannula and a faster deflation of the bubble once the type 1 bubble is achieved. But if the apex is very thin, you avoid this step. Instead of the 27 gauge needle originally described, most people now advise the use of bottom port blunt tipped cannula, which seems to have greater safety and increased success rates. So how do you know whether you reach the ideal plane? Manual feel, when you feel a sudden ease of resistance as you advance the cannula into the deep stroma. You can look at the reflection against the air bubble in the anterior chamber and look at the dark shadow between the tip of your cannula and the reflection against the air bubble. If you keep your pupil dilated against the retroillumination, you can look at the wrinkles on the Descemet's membrane. You can use pachymetry to assist it, and you can use a diamond knife to set it to 90% depth and then get a nice deep cut. If you have access to intraoperative OCT, you can create a track and then see whether the track is in the right depth or not. And if you have femtosecond laser, the newer ones, they have the ability to create a track using the femtosecond laser, which is again anterior segment OCT guided. When you inject air, you get an initial resistance and then a giveaway sensation as the bubble is formed. And then as the bubble expands, you again feel the resistance because the aqueous has nowhere to get displaced. And in such situations, if you persist with enlarging the bubble, you can end up with a rupture of the bubble. And that's the animation depicting the same, because once the bubble forms in a closed chamber, the aqueous has nowhere to get displaced. So there is a counter pressure from the aqueous that increases the intra-bubble pressure. And once it reaches its bursting point, it will spontaneously burst. And this study, which was published in 2017 from Buller, they did lab experiments where they mounted the donor cornea on artificial chamber. And in relation to the intraocular pressure, they looked at the dimension of the big bubble. And when the intraocular pressure was high, the bubble diameter was much smaller, which kind of correlates with what we have been trying to propose. And so what we do is we initiate the bubble. And if once the resistance is filled, you do a paracentesis to release the aqueous, minimize the counter pressure, and then you can expand the bubble further and minimizing the risk of spontaneous rupture. Once you achieve the bubble, the small bubble test has already been described, whereby you can identify. The other way is to do a paracentesis, make the eye soft, and then with the Merocell sponge, if you try to feel, you will realize that the central part will be firm if the bubble is present and the periphery will be softer. And recently, Massimo Busin has described the use of intraoperative OCT to identify the big bubble once it's formed. Deflation, yes, you can deflate either making the eye soft and then doing a quick cut using the 15-degree knife, or you can put viscoelastic, cohesive viscoelastic on the surface as described by Gosha and Mark Terry, and that makes the procedure much more simplified without the risk of perforating the posterior layer. You excise the residual stroma, divide it into 4 quadrants, make sure that you don't have a microperforation. You can remove the Decimet's membrane from the donor, but a lot of surgeons have found that even if you don't remove the Decimet, you can still have good visual outcome without any adverse effect. The size of the graft is, for ectatic disorders, is usually the same size. For other indications, you can make it 0.25 to 0.5 millimeter larger. Suturing technique using 10-0 monofilament nylon, you can use any suturing technique of your choice, interrupted, continuous, or a combination. I usually prefer a 0.75 millimeter bite on the donor side and 1 millimeter on the host side, 80% depth on the donor and about 95% depth on the host side. You can adjust the suture using an intraoperative keratometer, and in the first 2 to 4 weeks, you can do suture manipulation to minimize the astigmatism. The postoperative outcome is really good. There's minimal inflammation, and the graft becomes clear pretty quick because it has a healthy endothelium that's functioning. The femtosecond laser, I think the next speaker is going to give more details, but that's again, it allows much better, faster visual recovery. Alternatives are, instead of air, you can inject viscoelastic to create the visco bubble. And if you, after multiple attempts, if you have failed to achieve the bubble, you can create a peripheral pocket, and then you can go circumferentially to create the pocket, and then you can do the Marjan's peeling technique, and that's at near Decimet's level. So when you have scars involving the Decimet, I like to do the manual technique, where after doing a trephination for 85 to 90% depth, the cornea is initially debulked. Then you make a peripheral groove, and then I use the stromal pocket forceps to make this peripheral pocket near the edge of the trephination where the corneal thickness is adequate. And after you have done that, you excise the stroma 270 degrees, and then using like a modified peeling technique where the stromal dissector is basically assisting the peeling, you can maintain a uniform plane of dissection. As seen in the anterior segment OCT here, you can see that the residual bed is only about 30 microns. And a couple of months later, you can't even see the residual bed. That's ideal for indications like this case of blast stroma, where there are multiple foreign bodies in the cornea. Doing a stromal air injection may not be ideal. Or this patient who had a penetrating trauma with vitreoretinal surgery, silicone-filled oil-filled eye with astigmatism about 10 diopters. We went ahead, did a manual DAL with a secondary IOL after silicone oil removal, and he achieved a visual acuity of 20/40 with a regular cornea. And that's the post-operative anterior segment OCT. So there was a tissue loss at the site of the perforation, but the interface is quite uniform, which can indicate why the patient made a good visual recovery. Similarly, another case of a scarred cornea, where doing a DALC instead of penetrating keratoplasty, we were able to recover the good vision. Sometimes the DALC can be combined with limbal stem cell transplantation, and in this series of DALC with limbal autografts for unilateral chemical injury. We achieved good outcomes in the 7 eyes where this procedure was done in a combined manner. So the report which came out in 2011, it said that DALK is equivalent to penetrating keratoplasty if the minimal residual stromal thickness is less than 80 microns and it's uniform. It's superior because it preserves the endothelial cell density. Closed chamber surgery is much more safer, and it's a good indication where the endothelium is not compromised. And this is a nice paper out of Moorfields, published in 2019, where they looked at articles which had more than 100 cases. And if you look at the single surgeon outcomes, the outcomes of DALK are usually better because the surgeons are more experienced. But if you look out of the registry, you find that the penetrating keratoplasty data looks better than what you see with the DALK surgery. In this study, which is a multi-surgeon experience of 357 eyes, they achieved corrected visual acuity of 20/40 in more than 77% of the eyes. The perforation rate in the trainees, it was a little high, 45%. 24% required conversion to penetrating keratoplasty, and these eyes which converted to penetrating keratoplasty had a high rejection rate, and they concluded that a conservative management of Descemet's perforation is better rather than converting to penetrating keratoplasty because the risk of rejection is higher. And this is another paper looking at the comparison between DALK and penetrating keratoplasty and low risk and high risk indications. In the low risk, they did not find any significant difference, but in eyes which were high risk category for penetrating keratoplasty, DALK outcomes were better, both in terms of visual recovery and the long-term survival. In terms of complications, you do see double anterior chamber if you have a perforation intraoperatively, and it can happen even without perforation if you're doing it for macular dystrophy, or sometimes when you have a type 2 bubble. Usually managed by an air bubble, or sometimes you can even use non-expansile gas. It's important to avoid pupillary block and Urey-Zavalia syndrome. So a surgical inferior PI can be helpful to avoid this. So this is a surgery where we were doing a DALK and we ended up with a macro perforation. Ideally in this situation, in this scenario, you would have converted to a penetrating keratoplasty, but we went ahead, did a manual dissection near Descemet's, and then we put in our graft. And keeping the air bubble in the anterior chamber, we went with the reverse Sinski and we reopposed the edges of the tear. So we tried to approximate the edges. We had access to intraoperative OCT that was helpful because we could see the edges that were opposed. And postoperatively, the patient did well. At 3 months, he was up to 20/40, and the topography, if you see preoperative to postoperative, his cornea looks much regular. So this is a paper where they looked at the management of type 2 bubble. So if you try to expose the type 2 bubble, you end up with perforation in majority of cases. 75% converted to penetrating keratoplasty, and quite a few of them ended up with double anterior chamber and Urey-Zavalia. Whereas if you just do a manual dissection and do a small perforation to release the air, or you try and expose only the type 1 bubble, the outcomes were much better. They were able to have an intact DM in all eyes. Stromal rejection, epithelial, subepithelial, this can happen following DALK. The incidence varies from 4 to 24%. The risk factors are loose or broken sutures, pre-existing allergic eye disease, or if there is evidence of stromal vascularization. It responds well to topical steroids. So topical tacrolimus, in our experience, has been a good alternate instead of using long-term steroid in these eyes. There have been publications looking at glycerol-preserved, cryopreserved corneas for DALK and compared it with fresh corneas, and they found that the risk of rejection was lower in these eyes, although there was delayed epithelial healing. This was a paper that we published last year looking at the outcomes of gamma-irradiated corneal lenticules, which are basically decellularized. And we, in the 6 eyes that we did use it for DALK, we had good visual outcomes, and the graft remained clear till the last follow-up. Although compared to fresh donor cornea, the time to reepithelialization was almost double the time. Other complications, broken suture, epithelial melt, interface vascularization, lipid keratopathy, or interface keratitis can occur and needs prompt attention. This is a patient at 2 years who had 20/20 vision, had a broken suture which was left unattended, developed a microbial keratitis, treated and ended up with a scar. We were able to do a repeat DALK where we removed the first graft, which was a big bubble talc, and we put in a fresh donor, and we were able to restore his vision back to 2030. This was a patient where a talc was performed for chemical injury. He developed a lipid keratopathy. We went back, did a repeat talc along with simple limbal epithelial transplantation, and at 1 year, he still maintains a clear graft with an intact ocular surface. So in conclusion, talc should be considered as a procedure of choice for corneal diseases with healthy endothelium. Surgical techniques continue to evolve, ensuring greater success of big bubble talc. Pre-op evaluation and surgical planning is essential to minimize complications. And the femtosecond laser and anterior segment OCT, especially the intra-op OCT, may definitely help improving our outcomes in future. Thank you. Thank you for your patient hearing.
We will continue to move on, and I'd like to introduce Marjan Farid. Marjan is Professor of Clinical Ophthalmology and Director of Cornea, Refractive Surgery, and Cataract Surgery, and also Vice Chair of Ophthalmic Faculty at the Gavin Herbert Eye Institute at the University of California in Irvine. She's the founder of the Severe Ocular Surface Disease Center there. And Marjan is internationally known, well published, currently serves as chair of the scientific programs program committee of the EBAA and also the Cornea Clinic Committee of the FRCS. Marjan really has a lot of experience with femto-assisted keratoplasty and has really authored the key scientific publications. So we are pleased that she's able to join us today to tell us the updates. Marjan.
Thank you so much. Thank you both Sanjay and Ashiyana for inviting me. It's quite an honor to be here with you today and to listen to these wonderful talks, and such an honor to share the platform with these giants in our field. And since not everyone can be a magician like Dr. Fogla with those talcs, I'm gonna talk a little bit about how we can use the femtosecond laser to help us with some of these procedures. So here are my financial disclosures. I think the most relevant is Johnson & Johnson. I do use the IFS laser, femtosecond laser for these surgeries. So, you know, if we go back a couple of decades, our early challenges, maybe more than a couple of decades, maybe 20 or 30 years ago, things like surgical techniques, suturing, tissue availability and preservation, graft infection and failure were sort of our early challenges with keratoplasty. Those have been addressed, and I think our technology with our technology with surgical microscopes, suture materials, our eye banks that process and pre-prepare our tissue for us, our pharmaceuticals have really resolved some of those early challenges. Now, what patients really want to know is how quickly can I get back to work? You know, how quickly can I get my vision back? Do I have to wear a contact lens? I just want to wear glasses. Manual dexterity in some of our older patients is not great, and sort of the ability to have more regular corneal transplants and minimize higher order aberrations is really becoming important to address these minor modern challenges. So femtosecond laser technology, as we all know, we're using widely in ophthalmology, uses photodisruption. And the better and better our lasers get and the faster they get, the more interesting and better cuts we can make with them. So with our current femtosecond lasers, we really have gone through a variety of different shapes that we can use to customize our trephination pattern. And, we went from the top hat to the mushroom cut. There's other cuts as well, very innovative and creative. I think the zigzag here, which was conceptualized by my mentor, Dr. Roger Steinert, really is one of the better incisions that creates a little bit of a better hermetic seal. That angled edge provides a smooth transition between donor host and has a nice interlocking pattern, and it comes together nicely to minimize vertical and torsional misalignments. Here's what the laser screen looks like when we are programming these. We've sort of had these pre-programmed into a zigzag A, B, and C, with C being a 9mm anterior cut, a B being an 8.5, and an A being an 8. And you can see you can program the ring cut, which is at 300 microns. You can program the anterior and posterior side cuts. And then there's ability to make alignment incisions to help you orient, but those aren't essential. So those can be turned off where you want the laser to be done faster. So the patient is under the laser for somewhere between 30 to 60 seconds, depending on how much of a cut and what kind of modifications we want to make. One of the interesting modifications, and I'm going to go through these, that helps with our DALC procedures is the lamellar cut. The inner diameter can be brought down to about 3 millimeters, and that helps us remove that anterior cap before we use the big bubble into the posterior stroma. So here's one of the earlier cases here, and you can see once the cut has been made, we leave a little bit of posterior stromal tissue uncut, so you do need a good pachymetry map, so you can set that posterior depth, so it starts within the stroma, somewhere in the posterior stroma, about 70 microns from the thinnest point. And then finding the zig of the zag, if that makes sense, that point is very easy with the needle. So the needle drives about 300 microns depth, and the tissue comes together and locks together very nicely because it's almost like a lock and key formation. Post-operative appearance, even at higher mag at the slit lamp, you can appreciate that anterior lamellar and posterior cut. So you can really see those coming together nicely. And there it is on an anterior segment OCT. You can see the scar pattern. So we have that increased surface area for wound healing. So what does the literature say? We know there's more surface area for wound healing. That's sort of a given. But there's also greater mechanical stability of these incisions. And several studies looking at burst pressure with femtosecond laser versus conventional PKP wounds show better mechanical strength of those incisions. Several studies have also shown that because, more likely than not, because of that increased surface area and ability to scar faster, these eyes can have their sutures removed earlier than in conventional keratoplasty. So you have easier suturing, less suture tension, and as a result, we're getting less torsional and vertical misalignments, which we think is one of the reasons that we're actually seeing less higher order aberrations in these eyes. And I'll show you a study that looked at that. But there are implications for less astigmatism and more regular astigmatism is significant, because then these patients can go on to maybe having spectacle corrected vision versus contact lens. For those that prefer to be in glasses, or perhaps, you know, if they develop a cataract, they can then go on to have cataract surgery with a toric lens. So there's more ability with these kinds of grafts. So one of our early studies here showing less topographic astigmatism as early as the 1st and 3rd month compared to conventional keratoplasty, as well as earlier recovery of vision, with more patients achieving 20/40 or better vision at month 1 and month 3 compared to our conventional keratoplasty group. Our more recent results with a larger cohort in good visual potentials, we're seeing patients who can get spectacle corrected vision to about 20/30 as early as month 6, and these sort of maintain throughout the post-operative period. Manifest cylinder, so that cylinder that goes into their glasses, around 3 diopters on average. Of course, there's variability, but on average, we're seeing that, and we're seeing that maintained even after suture removal. This is one of the studies we did early on that really, we compared anterior higher order aberrations in conventional keratoplasty versus femtosecond laser zigzag versus DSEC. And you can imagine with DSEC, it should be very minimal because we're not really touching the anterior cornea. And we found the femtosecond laser better than conventional, so more regular anterior higher order aberrations than our conventional keratoplasty. Again, the implications for post-keratoplasty refractive procedures is increased because of this, things such as perhaps a LASIK on top of the graft or a toric lens to help correct that residual regular astigmatism. So we're seeing consistent levels of astigmatism, most eyes reaching their full potential earlier, month 3 or so, and maintained throughout. And then these seem to be stable even after suture removal. So what is in the literature very quickly? I just want to kind of go through what's out there right now. Several studies, but some of the highlighted ones. Chamberlain et al. Published study looking at 50 zigzag corneas versus conventional, and they found less astigmatism at month 4 and 6. This seemed to even out by month 24 post-op, but they did find earlier suture removal ability in the femtosecond group. Another published study in 2012 found faster visual recovery again in the zigzag group versus the conventional. This was a group that did use the mushroom pattern for the trephination and found less manifest cylinder, significantly less compared to the conventional keratoplasty group. Another paper showing significantly less astigmatism and better visual correction in the femtosecond laser group. And then there are studies that also, for example, this one in 2016 that said, well, in the long term, there's no significant difference in refractive outcomes. And I think one of the biggest issues is there's a lot of different studies that are looking at variations in both cut pattern as well as the diameter of the grafts. So I think what we ultimately need is a randomized trial prospectively looking at similar pre-op and post-op diagnoses in these groups, similar diameters of the cuts, and consistent suture patterns and trephination patterns. But does it really help? I think it does. Ultimately, we do have faster wound healing and suture removal and stronger wounds. So I would say that at this point, I think the femtosecond laser is really the future of sort of keratoplasty, that the key is to really get it into every corneal surgeon's hand, and that's the challenge. Now, just going to big bubble, the other sort of advantage here is that it really does help us find those different layers of the cornea when we have the femtosecond laser incision, and guiding the needle into that posterior stroma. And this is an eye that the anterior cap has not been removed. Is somewhat more straightforward and makes it a little bit nicer to find those and have more success rate at achieving the big bubble. And here's one of our early cases that we did using the big bubble technique with a femtosecond laser zigzag incision. We don't remove Descemet's membrane, and as Dr. Fogla mentioned, we're wiping off endothelium off of the donor and finding that the visual outcomes are very good and similar. The donor, again, has been cut with the same femtosecond zigzag shape here. Now, the other nice thing, as I mentioned earlier, is we can program that lamellar inner diameter down to 3 millimeter, which allows us to remove that anterior cap before bubbling the posterior stroma, which I think helps even more. So we see here at the laser, the cut, that lamellar cut at 300 microns comes down to the 3 millimeter range. It does not go beyond that. I wish it went to 0, but it doesn't with the current programming that's set up in the laser. So what we use is a crescent blade to just excise that final 3 millimeter central attachment there. You do need to do a pachymetry map to make sure, especially in keratoconus eyes, that you're not gonna perforate going into that 300 micron region in the very thin corneas. And let me just start this video here. So again, now we're just bubbling that posterior stroma. Again, visibility becomes easier, I think, when you're bubbling the posterior. So here we did an initial bubble that was incomplete. And the nice thing is we were able to sort of re-guide our needle into a different position and make a successful bubble here, as you can see. So the next step, I think, since again, all of us can't be magicians like Dr. Fogla, I wish we could make a successful big bubble every time. Can we make a perfect deep lamellar femtosecond cut? And we know that posterior corneal lamellar is very different from the anterior, and making a smooth cut like we do for our LASIK flaps is a challenge because we don't have those cross links through the anterior cornea. The strength of our posterior cornea is very different. But can we maybe adjust that femtosecond laser setting to make a smooth, deep layer cut so that our predictability with every DULC is the same? So it may require adjusting the energy, spot size, and separation, and perhaps avoiding making a big bubble or a manual dissection for more precision and predictability. Now, this is a cornea that was cut in the lab using one of these ultra-fast lasers. This was done with the Visumax Zeiss laser, which is used for SMILE. So the precision is a little bit more modernized with lower energy rates and very close spot size separation. And with that, we were able to create in the lab a very nice, smooth posterior cut, as you can see here. And we're using the anterior segment OCT, so a very beautiful, precise posterior cut. And we're hoping that we can start applying it actually live and seeing how the visual outcomes on these will be. But this would then help us potentially avoid making a big bubble. And this, I believe the residual stroma here was about 50 microns, and we saw no difference in endothelial cell loss, essentially, with a lab trial on these. So in conclusion, we think femtosecond laser keratoplasty is really the future of both full thickness and DALK. It does allow better precision, predictability, and wound healing. Future outlook, I think integration of technologies such as intraoperative OCT and newer generations of lasers that can really optimize our settings to make deep cuts within the cornea is where we need to go. And finally, I think what we need is advocacy and solutions so we can bring this technology, despite, yes, it is more expensive, but to be able to bring this into the hands of every corneal surgeon ultimately. So with that, I thank you so much. And again, thank you for inviting me.
Thank you very much, Dr. Farid. That was a fantastic finale to Transplant Innovations. So now we're going to open it up to questions. And the first question is for Dr. Terry. Dr. Terry, the question is, for older grafts, there was an issue that was mentioned on the group chat regarding how do you flip the scroll in older age grafts using the wave? I
haven't really seen a difference in upside down grafts that are older versus or younger. I mean, I think you're asking the question, if the graft is nearly flat and it's upside down, how do you flip it? I would start by obviously giving short bursts onto the iris surface so you can get one edge slightly up. And so if it's flat and then you get one edge kind of up, then you can go directly onto the posterior corneal surface with your short spurts to flip it over. So I think that the concept is you want to get an edge that you can impact with your short burst. The key also is to keep that chamber shallow. After you get one or two short bursts of fluid, then you want to shallow the chamber and then continue the process to get the graft not only flipped over, but to stay unfolded.
And what if you lose your S-stamp? Then what?
If you lose your S-stamp, you should be able to still see the conformation of the graft, but with a scrolling forward of your edge of the graft. So if that's the case, if you lost your S-stamp, what I do is I'll deepen my anterior chamber, so I allow the graft to show me which way it scrolls. So it's kind of a dynamic revelation for you, so that you don't have the S-stamp, and the graft is relatively flat. Then deepen your chamber, and you'll see one edge either come up or scroll underneath, and that's the way I do that. 90% of the time, you don't really need an S or an F stamp. 90% of the time, you simply look at the graft, you can tell that which way it's oriented. It's that other 10% of the time that you think you're right, but you're not really right, and the S or F stamp shows you.
And what about anterior segment OCT? This is for all the panelists. How do you use anterior segment OCT post-operatively? I love the anterior segment OCT. I mean, I use it for all my DMEC grafts and my DeSake grafts and all my DALKs. It's especially great for DALK because you can see those pockets of separation. And sometimes on the first day after post-op, you might have a small area of separation of your graft from the recipient desmase membrane stromal complex. And so it's nice to know that you don't have to put an air bubble in there to reattach if it's a small area, and the OCT shows you that.
the difference between a perforation and just a small separation. For DMEC graft, I don't ever use it on the first day. I use it on the 6th day because the first day you've got a large air bubble. It doesn't matter whether it's attached or not attached. The air bubble is doing it. It's on the 6th day that you want to know whether or not you need to rebubble. And for the DSAIC grafts, I use it on the first day because the first day on a DSAIC graft, if you see separations, it gives you an idea where you're headed on that.
It's a non-invasive test, can be done quickly. So I think I agree with Mark Terry that if there is a large air bubble, you're not going to get any additional information, especially for DMEC. For DSAIC, you want to see if there is any fluid, residual fluid, or any separation in the interface. And the other indication that I use in DMEC in my follow-up visits, I use it from the third or fourth day itself, because I want to look at the rate at which the edema is resolving, because sometimes if the patient's preoperative corneal thickness has been something like 700, 800 microns, and you put in a graft, so looking at how rapidly the cornea is responding also kind of tells you, that you have a good attachment and your endothelium is functioning. And we can also document, we can explain to the patient that, see, this is the surgery that we have done, and this is how it's benefiting, because they don't start seeing very well by the third or fourth day because there is an air bubble in the eye. So they are always a little concerned about, whether the surgery has been effective. But if you can show them on an anterior segment OCT, they kind of feel relieved that, okay, yeah, they agree with whatever you're trying to explain to them.
Mm-hmm. Any nuances as far as femtosecond and the use of anterior segment OCT, Dr. Farid?
Well, with the femtosecond laser, I think eventually things like, companies that are able to integrate those technologies, it's going to be fantastic. Right now, they're separate. So you're doing your femtosecond laser with the laser. If you have an anterior segment OCT, it really will help, I think, especially with DALK surgeries, to make sure you have that bubble before you cut into your posterior stroma. I think it would be very, very helpful. Potentially integrating these technologies will be able to perhaps move this into more of a refractive corneal realm, like we moved cataract surgery and the ability to use femtosecond laser to help us with our cataract surgeries, especially in complex cases. If we can somehow move corneal surgery also into a corneal refractive sort of arena, we may be able to actually utilize these technologies more widely.
I love these sessions. One of the challenges we've had with femtosecond laser in deep, trying to create deep planes, is that we end up getting these waves and we get these circles of disparity. And when you've got a keratoconus eye and you apply the cone to do your deep dissection, you now are operating with a flattened anterior surface. And the challenge has been to get that deep enough so that all the way across this irregular thickening, you get the same thickness all the way across. And I was wondering, how do you see we're going to get around that challenge?
With OCT, I think, and partially not applanating the cornea completely. So I think these newer lasers, again, lower energy, closer spot size, at least in the lab. We haven't done this in a human because you're absolutely right. With our current lasers that I have, you get the concentric circles, the irregularities, the ways, forget it. That's not going to be a very good visual outcome. But I think with OCT guided smart laser that can actually make the posterior cut precise all the way through, I think that's going to be the future, really, to be able to really program it down to that level of detail, and then to have the laser be so smooth that it can create that nice smooth posterior cut. I think that's sort of the holy grail if we can get to there.
How far away are we? How far away are we? Is it always going to be the future?
No, I think we are. I know Johnson & Johnson is working on another level. So these are the SMILE. I think this is where the SMILE technology is helping us, because the SMILE technology has to be so good for refractive surgery that that's what's going to be able to allow us to apply it then to keratoplasty. They're not going to make a laser for us corneal surgeons to do keratoplasty, but they will for the refractive surgeons. And then we can potentially apply that to corneal surgery. I think that's where it's going to be.
Zimmer already has the femtosecond laser with the integrated anterior segment OCT. So there, when you put in your depth of the cut, after you do the applanation, you can further refine the cut, just like you move your capsular axis and your thing for cataract surgery. There also you can play with the incisions based on the anterior segment OCT and place them even at the desired plane. And recently they have made possible to do corneal transplantation using the liquid interface, like what they use for the cataract surgery, at least the penetrating keratoplasty. So what happens is you don't applanate the cornea. So if they can translate that for lamellar incisions in the cornea, then we will not get those folds in the cornea, what you see in keratocornea eyes when you try to applanate the surface and the cornea is thrown into folds, and you see those concentric rings when you make a lamellar cut in those eyes using the femtosecond laser.
Professor Dua, you had a comment to make?
Yeah, you know, with DMEC and DALC, the cases left for PK are pretty grotty ones. Some have deep vessels, some have scars, thinning, irregular scarring and thinning. And those are the ones you're going to do PKs with your femto. So what are the challenges there in terms of cutting through the scar tissue and the regularity and precision?
Yes. Okay. So we have used the current femtosecond laser in eyes that have a lot of peripheral scarring, and you're absolutely right. The challenge of it going through the scar, sometimes the tags are a little bit more, and so breaking through those tags is a little bit more challenging. But we've been able to get through pretty significant scarred corneas, even with our current laser technology. So I do use it for scarring as well. Now, if a cornea is acutely perforating or so thin or ulcerated, those cases I'll do as a conventional keratoplasty. But peripheral scarring doesn't really worry me too much, or even a previous graft that scarred in and now failed, we can go back and use a femtosecond laser on that, and it still works.
I have a comment with regard to what Sanjay mentioned, very important point, that the configuration, the shape of, he said, the dissect tissue and the recipient, if that's not right, the attachment is not always accurate. I found that with DALC as well. If you're doing flat corneas and you're doing a DALC, and then you bring in a normal cornea and put it on, you get a detachment. You're more likely that there will be a non-attachment, if you like, and you have to put air. So that is not something we focus on, the configuration or effect, the K value of the recipient cornea versus the K value of the donor cornea. And that might be something that we'll be able to, as we fine tune and refine it, that might be a factor. There's another comment about, Rajesh mentioned, Sir Nicola's paper of desmetic and pre-desmetic DALC. And there's a nuance over there, because what he called pre-desmetic was the one where they did not get a bubble and they had to do manual dissection. What they called desmetic was where they got a bubble, regardless of whether it was type 1 or type 2, because that concept didn't exist at the time. So it is not the same as saying pre-desmetic DALC is where the PDL is retained and the desmetic DALC is a type 2 bubble. What they meant was pre-desmetic is manual dissection. You always leave a bit of stroma. Although the name fits well with the current concept of type 1 and type 2. Yeah, so the name fits well with the PDL and that. So that's just to clarify that little point. And then my tip for type 2 bubbles is, and people don't think that this is important, but every 1 to 2 minutes, you have to deflate the anterior chamber. Very often, it's not that you've deflated it once and that's okay for your 16 stitches. No, in fact, after every stitch, deflate before you pass your stitch. That's when perforations often occur, which is very, very disappointing that you've done, everything has gone fine and you're putting a stitch and it's gone. So how quickly the AC fills and the descendants becomes taut. And that's the time you touch it with anything, it's going to burst on you. So keep deflating the AC as much as you can through the procedure with the type 2, every step, every minute.
Professor Dua, your comments on the shape of the donor, I think we kind of overlooked this quite a bit. And one of the challenges, obviously, for corneal edema is we don't know the final curvature of the posterior cornea until you've restored endothelial function. So I think if we can work some of that out, that would really help from the endothelial side.
The OCT apparatuses help you do that, because nowadays you can do all that with an OCT device.
Interesting.
I think that differential in curvature is best illustrated by a couple of cases that I've done where the patients had keratoconus and also had Fuchs dystrophy. And they were a successful contact lens wear until their edema got so bad. And so then what I did was a DMEC. And on both those cases, what I ended up seeing on my OCT was there was a space at the cone between my DMEC graft, and my DMEC graft bridged across that posterior curvature, which was so abnormal in the keratoconus, that I couldn't get good attachment. It was really difficult to get the DMEC graft to attach centrally. And it was all about posterior curvature. Going back to what you said, Sanjay, about how that's an important aspect of getting all of your grafts, but especially if you're dealing with a combined keratoconus and Fuchs dystrophy.
Yeah, and you wouldn't expect that with DMEC, but it's only going to be worse with DSEC. But
yes, I've done DSEC like that too. I've seen that space. It eventually does go away, but it's a challenge.
So here's another thought. With when you do a type 1 bubble, you get maybe about 30 to 40 microns of tissue left of the recipient. Then you do a donor on the top from which you've not taken the desmids off. So you're adding another 30 to 40 microns of tissue more than what it should be, right? So if you then so patient effectively got 2 desmids and 2 PDLs. So the total cornea thickness is about more than 40, 50 microns more than what you would have in the DMEC, which would be only, but nothing more. And the DMEC would be exactly the same. And here you've got about maybe 30 to 40 microns more of tissue because half of it is its own and the half you're bringing in. That little extra difference does not make any difference to the patient's vision, or does it? And when we're talking about, thinner the better, I think below 100, it doesn't matter. Because below one, as Rajesh showed in one of his pictures, very nice, smooth, manual DALK. And that was manual. That wasn't femtosecond. It looked like femtosecond.
No, that was manual.
I know, but that's what Marjan said about you was right, that, it's very smooth. So there you left more than 40 microns. You left quite a bit of thickness, but I assume that the visual outcome was still pretty good.
No, I think the surgical technique, the trick is that you make the plane in the periphery, but the central part is something like a peeling technique. So you're not surgically trying to dissect a new plane. You're basically using the left hand to try and peel the tissue. And as the stromal fibers separate, you use your dissector just to carry forward the plane from the periphery across the central cornea. So you get a uniform plane from the periphery wherever you have initiated it across the cornea. Whereas if you take a dissector and try dissecting the stroma, you will end up having thicker on one side and maybe on the other side, it may become a little deeper, you get variations. So it's basically a modified Malbrand's technique. So
I'm also really surprised, when you do a repeat DALK with a type 1 or even a type 2 bubble, come back a year, 2-3 years later, how easy it is to peel it off.
I've never done with a type 2. With a type 1, yes. If you get into that interface from the graft-ose junction, then the interface is just like lifting a LASIK flap. It never really heals. So in this case, patient had an infective keratitis and the scar appeared like full thickness. So even when I had to dissect, the area where the scar was involving the pre-Descemet's layer, I had to do a little bit of dissection to free it at that point. When I put in my graft, surprisingly, the second graft did very well. But you could see some folds originating from the original site of infection, which were there because of the scarring process involving the pre-Descemet's layer. Any kind of complications that happen in DALK, I think we should not jump to convert. Most of these complications can still be managed. Like you saw me, I had a large macro rupture where we put in the graft and we then went in with a reverse Sensky, opposed the edges, put in a large air bubble, and we were able to successfully get a clear graft after that.
I was going to comment about Sanjay's presentation. Sanjay, you showed some wrinkles in the DSEC graft that you felt was compromising the visual quality, and also I don't know if you showed them in a DMEC graft as well. But when I'm doing DALK surgery, I will get a mixed, usually a big bubble, not a big type 1 bubble, and then I can also get a type 2 bubble. I've had some cases where I got a very large type 2 bubble. I mean, over 90% of the area. And as everyone knows, if you look at that bubble the wrong way, it will burst apart. And so what I've done is I've not gone in and, Dua said that you could go in and remove the air from that interface. I've not done that because it scares the heck out of me. So I've left it in place and let the air resorb over the following week after surgery, after a DALC with a type 2 bubble. And what I've seen is that, yes, it does resolve, but it leaves wrinkles in the descemet's membrane that are even different than the wrinkles we see when we're collapsing a keratoconus cone with a DALC. So my question is to Sanjay and others of you, if you have wrinkles in descemet's membrane, if they're in the periphery, they don't seem to affect the vision. I also haven't noticed that it's affected the vision when they go through the center, but I may be just being wishful thinking. What are your thoughts about wrinkles in descemet's membrane that are extensive from a type 2 bubble? And would you guys leave a type 2 bubble in place and let it resolve spontaneously? Or should I be courageous and go in and remove that air?
Well, I think the wrinkles were there regardless of the air. If you look at the surface area of the descemet of an advanced cone, it's quite a lot compared to the surface area of the new cornea you're putting on. That excess tissue has to go somewhere, and it usually forms wrinkles. And often there are concentric wrinkles at the periphery. But what I've seen is if you get an inadvertent tear, even in a type 2 bubble, there might be a distal wrinkle as the slack is taken up by the fold. So if it is in the visual axis, I suppose it will cause some problems, which we can measure or not is a different matter, but it will cause some kind of an aberration. But if it at the periphery, it doesn't matter. But do expect some wrinkles, especially if the cone is large and if the patient is more than 30 years or so, the elasticity is less. So it won't sort of come back. It will stay flaccid.
I just wanted to ask a question of Dr. Colby and her thoughts perhaps on the future of DSO and maybe even the future of DMEC as well with cultured endothelial cells. Is that going to replace all of this? And will a future generation of corneal surgeons not even know how to do EK anymore? What do you guys think?
Let me peer into my crystal ball.
Yeah.
I think the power of the cultured cell technology is that it's applicable to all forms of endothelial dysfunction, whereas decimate stripping is useful in only a select group of patients. There's a lot of work going on right now about trying to intervene in the pathogenesis of Fuchs earlier on, whether it's through gene therapy or interruption in some of the involved pathways. Those are challenging studies to do because, as we all know, Fuchs, you don't have a good endpoint for early Fuchs. Counting the number of guttae, what is exactly do you measure to see an impact? But there are a lot of things that I'm aware of that are currently under investigation. So I think keratoplasty is safe for the moment. But I think just all of us on this call have, except maybe Ashiyana, have had to learn new techniques after we've finished our fellowship. And I'm sure that that evolution will continue.
Well, I have a closing question for all of you in all your expertise. So now we're talking about refractive, right? Marjan brought up the word refractive corneal surgery. So to close up from everyone, I would love to get your guidance on doing cataract surgery at the same time as doing a corneal transplant. Where are we going? Are we talking about multifocal lenses? When are we going to talk about multifocal lenses? What's the future when it comes to doing triple procedures, including the DSO? Dr. Colby, will you start us off on that?
Okay, again, you want me to predict the future?
Since you're already looking at that crystal ball, we thought you might as well.
Okay. You know, I think that certainly there are people who are putting in premium lenses in patients with corneal disease that need keratoplasty. There are certain populations where you might get away with it. You know, an approach of doing a DMEC and then letting the cornea settle and then putting a premium lens in might be more more accurate than trying to do it all together. You know, I'm a minimalist, honestly, and I wear contacts and reading glasses, and it's not terrible, right? Myopia, little myopia is actually a good thing.
Any procedure that needs sutures, no. Any procedures where you cannot do the K readings of the recipient, no. Because it's all guesswork, whether you use the opposite eye Ks or standard Ks or historical Ks, it's all guesswork. The premium lenses, even in non-keratoplasty patients, I'm very conservative with. But with keratoplasty, I think DMEC, like Kathryn said, or perhaps PDEC, you might want to do a premium lens. But I would still wait for it to settle everything, and then perhaps at the second step, or as a first step. So do your lens first. Which is what I do. I rarely do the two together. If I'm doing a DMEC, I would do the lens first, and then come and do the cornea later, the DMEC.
And Dr. Terry, what about ocular adhesives in DMEC, and does that change the game in terms of your triple procedures, or do you do any premium lenses right now with your DMECs?
Let me just make a couple comments on transplants and triples. I've probably been doing penetrating keratoplasty longer than any of you guys because I'm so damn old. But my technique for my decision making in penetrating keratoplasty in a patient with a cataract has changed over the years, and I no longer ever, except in monocular patients, I no longer do a triple procedure for penetrating keratoplasty or DALC. And the reason is because it never makes any sense to be guessing at what the artificial lens should be. And so even if a patient has a very severe cataract, but they need a transplant, I will do the transplant first, and I'll take the time, a year, to get all the sutures out, or actually in 2 months if it's Marjan's femto transplants. But I'll wait a year and let the patient not see well because they're cataract for nearly a year. And then when all sutures are out and they have 3 topographies in a row that are stable, then I will go in and I will do a cataract surgery, and I'll get them close to emetropia of a spherical equivalent. And I will also consider doing a toric lens if the symmetry is right and all the other factors. But I think it's important to realize that when you're doing a triple with a penetrating keratoplasty or a DALC, you're now committing that patient to an unknown refractive error for the rest of their lives. And I think it's incumbent on us to think about the long term, not just getting it all done now. Now, in terms of endothelial keratoplasty, I don't do any multifocals or extended depth of focus lenses in my DMEC triples. I will do toric lenses if there is sufficient astigmatism, not just a diopter. It has to be more than that, usually more than 2 diopters, because there's such variation. We published papers on this already. So I will do triples, and I believe more in triples for EK than I do for any of the other transplants. In terms of tissue glue, I'm not quite sure what you mean in terms of EK.
For suture, instead of sutureless endothelial keratoplasty, are you doing any adhesive tissue adhesives?
The incision is only 2.5 to 3 millimeters, and although I do sutureless cataract surgery, 2.4. I always put a safety suture because of the gas bubble and the air bubble, and I just want to make sure that there's no eye rubbing and that sort of thing. So that's the purpose for that. And that one little suture is out in 1 week. So I don't see a place for glue for a 3 millimeter or less incision.
So here's a question for everybody, because I grapple with this all the time. Toric lenses I do quite a lot of, and particularly keratoconus patients, you've done your DALC, sutures out, but she's got 4 or 5 diopters of astigmatism. The lens is usually clear, then I would go in and put a secondary toric lens, either an artisan iris clip or a PICL. Those can be changed. But if you do a cataract and put a toric lens, and that graft then later gets more astigmatism because post-bed keratoconus, or it fails and you're doing another one, you've got a completely wrong lens inside. And taking that out is a big challenge. So should we, even if you're doing a cataract and needing a toric lens, do 2 lenses rather than 1? So in the bag, always monofocal, and the torosity corrected with a second lens, or go for 1.
Dr. Fogla, do you want to chime in on that?
Well, I'm even more conservative. I take a stage approach. And even for EK and toric lens, I've found that when you do, because preoperatively, if the cornea is edematous, you cannot get a fair estimate of the astigmatism as well. And often I've found that even if you do a DMAC, the astigmatism changes in the postoperative period. And sometimes we find a shift in the first 3 months as well as the edema resolves from the center to the periphery. So making an estimate and doing a toric lens, it's a little challenging for me. Or maybe we see patients who are far more advanced Fuchs than what people see in the West. So I think the approach of either doing a DMAC first, letting the corneal edema resolve completely, and then go back and do a cataract surgery with a premium lens like a toric lens, that would seem much more appropriate. Otherwise, I would put a regular lens, and if the patient still has astigmatism, if it is astigmatism less than 4 diopters, 5 diopters, I can think about doing a topo-guided PRK to try and correct that once the patient has a stable topography. If it is higher than that, then maybe I will try and put in one of those phakic intraocular lenses, something like a toric ICL, which can go even in a pseudophakic eye, and you can try and correct the astigmatism that the patient has. And if it changes in future, you can always remove it from the eye. So that would be what my approach would be. In fact, some of these grafts with high astigmatism, I have taken the approach of doing a femtosecond laser assisted astigmatic keratotomy using a 6.5 or 7 millimeter zone. That kind of brings down the astigmatism from, if let's say somebody has 9 or 10 diopters, it brings down to about 2.5, 3 diopters. And once it remains stable, if the patient happy is fine. If he still wants further treatment, then we can do a surface ablation and try and bring him close to emmetropia rather than trying to treat the whole thing. But nothing like putting in a customized toric intraocular lens, which works like magic in patients who have high astigmatism. I had a patient with DALC who had an astigmatism of something like 16 diopters, and there was no way I thought I will have to, but he had a cataract, so we got a customized IOL. I put it in, next day he's 20/30 unaided, and he was the happiest. He said, wow, you've done magic. So this is how a customized toric lens, in the bag really works very well. And I think from these guys from Brazil, they have the AcuFocus, the IOL with the pinhole, which also is very good for irregular corneas where you have high astigmatism. Sometimes you can implant that and you can achieve great outcomes.
Well, I think that we have a whole team of magicians here from all over the world. I can't thank you enough to each one of you for being here. I think this conversation could probably take us until 2022 at least. And I'm looking forward to next year's session to see what's new, what's more innovative, what's changed in our answers, in our experience, and in our wisdom. But until then, please do stay safe. And I want to thank all the esteemed faculty for taking time out of your busy, busy schedules to be with us. This has been fantastic. So please stay in touch, and I look forward to seeing you post-COVID healthy.
Thanks, everybody.
Thank you.
Thank you.
Thanks to all of you.
Bye. Thank you.
Bye. Take care.